Good morning to all of you. And we're about to start this sets on Haematuria, one of the common topics. And we have an eminent panel today joining both physically as well as online. From Colombo, we have Professor Neville Perra. He's about to join. And we have Dr. Manjuli Vijayavadan, Senior Consultant from National Hospital, Colombo. And Dr. Nirosh, myself. And Tilina Samarasinghe contributed a lot and he's joining online. And Dr. Manjuli Herath from Kandy. He has already joined online. So this program we'll be physically conducting in Colombo, but we'll be sharing through Zoom platform with our regional centers, starting from the northern end, Jaffna, Anuradhapura, Kandy Peradeniya, Kurunegala, and also Batticaloa and Galle. Before we start, it's a bit of a sad note. We all had a very sad news yesterday. One of the eminent surgeon from the Northern Territory, Jaffna, Dr. Sudarshan, and who had been a very enthusiastic teacher who has contributed so much to college as well as the surgical fraternity throughout last decade or more. And unfortunately, he passed away yesterday, a sudden death, when he was attending another teaching course, one of the college pre-Congress workshops in Jayawardenepura University. And so I take this opportunity to pay tribute to this leader. And also may I ask the audience to stand up for 2 minutes silence, please. You may take your seats now. So the outline of the program today, we thought of touching upon the basic topics, maybe for 20 minutes each. Introduction on hematuria, followed by common conditions such as upper tract RCC and then bladder cancer. And after a tea break, we will proceed with the case discussion. So feel free at any point. You can disturb even in between the lectures. And then obviously the case discussion will be a two-way interaction. So we'll keep the momentum going. And hematuria, of course, initially to be done by Professor Balagobi from Jaffna. But with the obvious reasons, he had to withdraw from the program, but he has contributed. And so I took over the responsibility to do a small presentation on hematuria. So what do you mean by hematuria? Any idea from the audience? How do you know whether it's hematuria? Now, if you look at the numbers, number of red cells from country to country where you practice, and the guidelines, it varies. For example, if you look at the European or the UK guidelines, and usually they go for 5 red cells in the high power field. And if you look at the American guidelines, it could be up to 10. And Australian guidelines, again, it's different. So it's slightly variable. In general, if it is more than 5 or more red cells, then that is considered significant. So two terms, visible and invisible, and replacing the previous terms, frank hematuria and microscopic hematuria also comes under invisible hematuria. So these are the modern terminology that we use in our day-to-day practice now. Obviously, visible is quite visible with your naked eye, red colored urine. And then the question arises, what are the other instances you could get red colored or cola colored urine, or which can resemble hematuria? I'm sure you all know from your medical student days the list. But at our level, whenever somebody comes and tell you red urine, we never think about their diet, beetroot and things. Obviously, you need to focus on hematuria. So if you look at non-visible, that will have microscopic, where you demonstrate red cells under the microscope. Or the technique, if you move to other countries, the European countries, you can see they have a very rapid way of testing. Dipstick. We will go into a little bit of detail in next slide. Then the question is non-visible hematuria, when it is significant. It's a very common encounter. If you just check randomly urine samples of the population, and I'm sure, especially in female population, you will see positive red cells, provided that it makes sure that they are not menstruating at the time of sample collection to exclude the possibility of contamination. So if the sample contains red cells, significant number of red cells in 3 consecutive samples, at least 1 week apart, then that is considered significant. Then little bit about dipstick hematuria. That is a chemical reaction, because we know hemoglobin has peroxidase-like activity, which catalyzes oxidation of chromogen by organic hydrogen peroxide on the test strip, and resulting a color change. Here you could see the strip, when it turns into blue, that is indicated positive. Depending on the intensity of color, you can give the number, which will indicate the degree of hematuria. It's very sensitive, but the downside is specificity is variable. So there are a lot of false positives. Therefore, if you encounter a positive strip test for blood, then obviously you need to send the same sample for microscopic analysis to confirm the presence of red cells that will confirm microscopic hematuria. So the question is, why do we bother about hematuria? Why do we consider it a significant symptom? Now, if you look at the causes, number of medical causes, starting nephrological causes, starting from glomerulonephritis and all these, the bleeding diathesis, so many, you can list a lot, but I will mainly focus on urological causes. And hematuria is considered as a red flag sign or symptom for urological malignancy, starting from bladder, renal, and upper tract urothelial cancers. And of course, prostate cancer, they also can present with hematuria, but which is not a common scenario compared to other 3. So if you ask to name the urological cancers according to the incidence, I would say bladder, renal, and upper tract urothelial should be the answer. And of course, the other common non-malignant conditions can also be considered. Recurrent UTIs, calculi, and of course, BPH, very notorious condition to give rise to very significant hematuria, usually torrential bleeding. And there are fragile blood vessels around the bladder neck with the BPH process. And these vessels, they rupture and they bleed a lot. Usually these patients, when they bleed, they need the irrigation and then clot evacuation and things if it is very significant. and you look at the patient's age, the incidence of malignancy obviously increases after 45 years. And if it is visible hematuria, chance of them harboring a malignancy is about 14%. This number slightly is variable depending on the series you are looking at. And if it is non-visible hematuria, chance of having a urological malignancy about 3%. Now, what is our approach to hematuria assessment? Now we know the age is a risk factor. So obviously the advancing age and considered as a risk factor for urological malignancies. So are we really going with the age? Now, if you look at the most of the guidelines, including previous Sri Lankan guidelines, you could see the hematuria assessment considered significant. The hematuria approach is mainly targeted the population more than 40 years, considering the higher risk of malignancy. But the trend is is not the same. Now this number, the age is no longer valid. Whatever the age, irrespective of the age, if it is significant hematuria, which cannot be explained otherwise, you need to fully investigate them. But obviously, if they are having one or more risk factors, you need to pay more attention. So you could see the smoking, occupational exposure, and the positive family history are some of the leading risk factors for some of the urological cancers. In our practice, we do see even young people coming with renal cell cancer. Now, I would say last 1 year, we would have seen more than 10 cases of young people, less than 40, 45 years with RCC. And same would apply to even bladder cancer. The youngest bladder cancer, I'm sure Manjula sir and Neville sir would agree. And we have seen even 17 years, 18 years. I think there was one patient at NHSL, even 12 years. Kid diagnosed with bladder cancer. So you can't really go with the age, it's just a number. And the last thing, it's very important. If you go to the practice, if you look at the physicians, general practitioners at each and every level, and we tend to give a false reassurance to our patients, particularly when they present with one episode and then for some funny reason it settles. And they will present with the second episode maybe months or maybe a few weeks or months later. So if they just present with one episode, sometimes the patient here himself consider it's not significant, just one episode and it's settled on its own. And even the clinicians consider that is not significant because it's just one episode. Similarly, when you get a patient with hematuria, generally the practice in the community, you tend to treat with antibiotics thinking it's a UTI. And for funny reason, it settles. Then you are happy because your antibiotics has worked and patient is also happy, hematuria has settled. You are attributing that to the UTI. And it's not uncommon to find small renal calculi, particularly the calyceal stones when you do routine scans in general public. So some of these people, when they present with hematuria, we tend to attribute hematuria to these tiny little stones. And a lot of our patients, they are on anticoagulants and antiplatelet drugs. And unfortunately, sometimes the onset of hematuria nicely coincide with the starting of anticoagulants or the antiplatelets. We tend to attribute to these drugs. But ideally speaking, we should never do that. This is a false reassurance. There are plenty of examples to show that patients harboring malignancies and despite these factors. And I had a patient who had a MI, who had a PCI, started on anticoagulants, and week after presents with hematuria. Everybody thought it's due to anticoagulation, but found to have a bladder lesion. It turned out to be a malignancy. So maybe the anticoagulants is just a trigger factor, but there may be underlying lesion which leads to bleeding. So how are we going to evaluate a patient with hematuria? Obviously, we need upper tract evaluation with the help of imaging and cystoscopy, which is essential in the case of evaluating the lower tract. In addition to that, the role of urine for cytology, we will discuss under bladder cancer. that is something you need to be aware. That is also an optional thing available. And certain centers, they have a practice routinely, they do urine for cytology in other countries. So out of all the available modalities, what are we going to select? You have the options of ultrasound scan, non-contrast CT KUB, you have the contrast enhanced CT of the pelvis and the CT urogram. Most of the practice is basically whenever you see a patient, you proceed with ultrasound scan KUB, which is commonly available, freely available. The question is, are we going to stop there? We do ultrasound scan and you get a negative result, and are we happy and are we going to stop there? And patient coming with a hematuria without any evidence of a ureteric colic, is there any value doing an uncontrast CT KUB? Because non-contrast CT KUB basically targeting stones. So when we are not quite sure what the underlying cause for the hematuria, are we going to end up with an uncontrast CT KUB and stop it? The first two modalities, the problem, we are basically looking at a soft tissue lesion, either the kidney or maybe the renal pelvic ileal system or the ureter. So the ultrasound scan, KUB, and the non-contrast CT, both of these modalities are not really sensitive to pick up soft tissue lesions in the upper tracts. Therefore, though you get a negative result, if it is a significant hematuria, it's compulsory you proceed with a contrast imaging. So what is the difference between contrast enhanced CT, the triphasic CT, and the CT urogram? The same contrast, same CT.
Mitrato mo dyan. Oo. Oh. Sama na yung spice.
1 second, we are getting a small disturbance. And the difference is basically your timing. In the CT urogram, basically you are looking at late films, delayed films, and that will give the best imaging of the renal pelvis, calyces, and the ureter. So whatever the fill-in defects and the abnormal focal thickening of the ureter or maybe the renal pelvis, that can be picked up with your CT urogram. So if you are investigating a patient with hematuria, then the investigation of choice is basically CT urogram. And the role of cystoscopy, basically you are looking at the bladder tumor. So whatever the image, the best imaging modality, even MRI if you do, still there is a chance you can miss early bladder lesions, particularly carcinoma in situ and flat early bladder lesions in your all your imaging techniques. So therefore, the imaging is not going to be a substitute for your cystoscopy. So that is essential that you perform a cystoscopy to pick up lesions in the bladder in a patient presenting with hematuria. Here you could see the initial top slide showing a very flat velvety-like lesion, red lesion, erythematous lesion. This could be inflammatory most commonly. But on the other hand, this could signify underlying carcinoma in situ, which is a very nasty condition in comparison to other malignancies. Here in the bladder, carcinoma in situ considered as a very bad prognostic feature. And below you could see typical papillary urothelial cancer, front-like structures nicely projecting into the bladder. And there is another one next to it showing solid papillary mixed lesion. So all of these are very significant and then they need further evaluation. So the take-home message about hematuria, every hematuria patient needs active exclusion of urinary tract malignancy unless you are looking at obvious stone which is causing hematuria or maybe obvious infection, urinary tract infection confirmed with cultures. All the other patients, if you have no clue what's going on, they all need active investigations to exclude underlying urological malignancy. Any questions? Questions from the audience here in Colombo as well as online teams joining elsewhere, please feel free. Anything you want to clarify in your exam point of view? We have the eminent panel here, and Professor Neville Pera also just joined now. So you can ask any question. Any doubts you can clarify now about hematuria assessment in general. Okay, in the absence of questions, feel free, even later on we can discuss, and we'll move on with the next one. That is by Dr. Niroshan Kodikar. He will talk about renal tumors.
Good morning to you all. I'm Dr. Niroshan Kodikar, consultant urological surgeon from Army Hospital, Colombo. I'm going to speak about the management of renal cancer with you. So it is the seventh most common cancer globally, and it accounts for 2% of the cancers worldwide. We have considered this as a tumor of elderly, but as Dr. Ranga Vikramarachit just mentioned, now we are seeing more and more young patients coming with renal cell cancers, and there's a slight male predominance as well as more common in people in Western countries. When it comes to the incidence, obviously the incidence of detecting renal cancers are on the rise, and I'm going to discuss about this more during the latter part of the lecture. And I'm sure that both you and I are going to see more and more kidney cancers because of this increasing trend. And this is the common histological subtypes of renal cell cancer. I'm sure that all of you know about them. And you have to have some idea about the percentage, because clear cell renal cell cancers are the most common type, followed by papillary, and chromophobe. And it is nice to have an idea about certain point mutations or genetic mutations which can cause kidney cancer. At registrar level, it's nice to know that VHL gene mutation can cause clear cell cancers, as well as P53 gene mutation can cause chromophobe cancers. You can forget about the other mutations mentioned here at your level. And about the presentation of kidney cancer, it is very important to realize the classic triad of kidney cancer, which is loin pain, loin mass, and hematuria, is only seen in 10% of the patients. So most of the time, we will get a referral from the GP or from one of your colleagues mentioning this patient was found to have a lesion in their kidney. Please see and advise. So, which brings to the topic of incidentaloma. So, incidentaloma means a kidney tumor which is incidentally detected during some other investigation. For an example, a patient is undergoing a routine checkup or undergoing an ultrasound scan for hypertension or suspected CKD, will be found to have a kidney lesion. So this accounts for more than 50% of the kidney tumors found currently. That is one reason that incidence of kidney tumors are keep on rising. And it is very important because kidney cancer is a cancer which has a unique genetic predisposition, because kidney cancers can have up to 8% of the time can have a hereditary predisposition. So it is always important to keep that in mind when you see a patient with kidney cancer, especially if the patient is relatively young. So at registrar level, I believe it is nice to know a couple of hereditary cancer syndromes as well as which histological type of kidney cancer they are associated with. For an example, von Hippel-Lindau disease syndrome is associated with clear cell RCC. Hereditary papillary renal cell carcinoma, obviously associated with type 1 papillary RCC, and Birt-Hogg-Dubé syndrome. You should know it is associated with chromophobe RCC as well as oncocytoma. If any medical students are seeing this presentation, if they know a couple of genetic syndromes that is associated with kidney cancer, I believe that's more than enough. And there's another unique presentation for kidney cancer, that is the paraneoplastic presentation. What is a paraneoplastic presentation? These are systemic signs and symptoms that are secondary to the presence of a cancer, but not directly caused by the tumor itself or its metastasis. So when the cancer is there, due to some unexplained or sometimes explained methods, there are a couple of symptoms and signs that you can see. So actually, kidney cancer patients can present with 10 to 40% of the time, they can present with paraneoplastic syndromes. So it is essential at registrar levels, you have to know couple of paraneoplastic syndromes associated with kidney cancer, which I have shown here. Especially this hypercalcemia, young hypertension, polycythemia, those are the most important paraneoplastic syndromes. And when it comes to the etiology of kidney cancer, generally kidney cancer occurs in smokers, obesity, hypertension carries a risk. As I mentioned before, family history carries a significant risk. This family history is not only the hereditary syndromes that I mentioned, but even just a first or second degree relative having kidney cancer will increase the risk by 2.5-fold. And also, there's a question about whether it is associated with diabetes, because some people say diabetes treated with metformin is bit protective when it comes to kidney cancers, but diabetes treated with insulin is a risk factor. So just keep an idea about it. And as you know, because of our lifestyle as well as the metabolic syndrome, the kidney cancer incidence might be rising because of these risk factors are so prevalent. And how are you going to investigate a patient who's coming with a renal tumor, let's say incidentally detected on ultrasound scan? The first thing is you have to do a full blood count and renal function, because those are the basic investigations, because these tumors can bleed. So HB might be low, as well as renal functions are very important about deciding the further management. If you want to take out a kidney of a person with a kidney cancer, you should make sure the other kidney is functioning well. And then the next most important investigation is triple phase CT scan. So this is the investigation of choice in investigating for kidney cancers. And what do you mean by triple phase CT? So it is a contrast CT scan where we inject a dye and then take a couple of CT films, CT films with a unique time interval. The first one will always be non-contrast CT film, and then we take another film in about 30 seconds time, which says which is the corticomedullary phase. It will differentiate pseudotumors from a tumor, because tumors are enhancing. But the most important phase, I would say the nephrogenic phase. I think registrars should know this. It is 100 seconds after the injecting contrast. The importance of nephrogenic phase is that it can differentiate kidney tumors which occurs in the medulla, not the cortex. Because if I show you this, so the leftmost corner one is the non-contrast phase, and this is probably a medullary tumor, not a cortical renal tumor. In the corticomedullary phase, you can see there's both tumor as well as the normal kidney tissues are enhancing. But when at the right hand corner, you can see the nephrogenic phase, that is the after 100 seconds from contrast injection. You can see the rest of the parenchyma is lighting up, but the tumor appears hypo intense, and it is clearly visible. This is the importance of triphasic CT scan. And if I go back, So this is the diagnostic image. But all of you know, when we diagnose a tumor, we have to stage it. So when we do the triphasic CT, we have ruled out all the abdominal organs and the pelvic organs. So only the CT chest, or the chest, is the one which is remaining. So to complete the staging investigation, better to order CT chest as well. But having said that, remember, smaller the tumor, let's say if it is less than 4 centimeters, which I will be coming to discuss, the chance of metastasis is comparatively low. This study shows if it is a smaller tumor less than 4 centimeters, the chance of metastasis is maximum chance is like 8%. So this is why now EAU guideline sometimes now say you can skip the CT chest if it's a very small renal mass, because the chance of mets is less. But at your level, I would say, for the sake of completeness of staging, I would do both CT chest as well as triple phase CT IVU. And then I will come to the small renal mass, as I told you. So a small renal mass definition you should know. It's a kidney tumor measuring 4 centimeters or less in diameter. And these small renal mass are very important because, as the word says, it's a small mass. So we should be able to manage it without removing the kidney. For an example, doing a partial nephrectomy, which I'm going to discuss next. But you should know which tumors, which small renal masses that we can manage with partial nephrectomy, and which we can't manage, because there are a couple of scoring systems. One I have shown here called renal scoring system. This gives couple of points and assess the complexity of partial nephrectomy if we are going to encounter. For an example, the size of the tumor, diameter, and whether it is exophytic or endophytic tumor, and nearness to the nearness to the collecting system. Because if it is a large tumor in the middle of the kidney, and if it is not exophytic and buried inside the kidney, doing a partial nephrectomy will be very difficult. So we can justify just to go ahead with radical nephrectomy, even though if it is a small renal mass. That's why these scoring systems are important. Then you should have some idea about Bosniak classification, because Bosniak classification is originally a CT-based classification of renal cysts, because it's very common for you to encounter patients coming with renal cyst detected incidentally. So Bosniak classification ranges from stage 1 to 4. So 1 and 2 we generally considered as benign, and there's a subcategory of 2 called 2F, which carries about 5% risk of becoming malignancy, and Bosniak 3 carries a 50% chance of malignancy, and Bosniak 4 is, we consider, is 100% or more than 90% chance of malignancy. So if you have that sort of idea at your level, I think it's good enough. And these are the other imagings, which I am not going to touch more. But remember, sometimes if the patient is pregnant, or if we need to avoid contrast or radiation, we can go ahead with MRI scan. And also the last one, which is the DMSA scan. So DMSA scan is very important, because if there's a doubt about the renal impairment, so we can check how the split functions are, and then decide whether it is safe to remove the kidney or part of the kidney, because it will give an idea about the function of the other kidney. So you should know about the TNM staging. Especially they will ask about the T3 stage, I would say, because it is the one which is most confusing. And you have to know this by heart. And also, if you are actually brilliant, then you can just have an idea about this nerves and Cinque classification, because kidney cancers are notorious cancer which can spread through the renal vein. We call it permeation. So when the tumor can invade into the renal vein and permeate into the IVC, and it can go up to the heart or the atrium. So just remember the name. There's a classification depending on the level of thrombus. I think that's good enough. Then about the renal tumor biopsy. Generally, when we detect a cancer, any other cancer in the body on the CT scan or radiology, the next step would be going for a biopsy to get a histological confirmation. But it is very important to understand, if the CT scan is conclusive of a renal cancer or renal tumor, you don't have to go and poke a needle and do a biopsy to confirm it histologically. Having said that, there are certain indications you can consider renal biopsies. For an example, if the patient is having bilateral masses, bilateral tumors, and also then we can't just go and remove the both kidneys. No, so sometimes it is better if we can do a biopsy and conclude that this is a tumor or not. And also, if there are suspicious of metastasis from a primary malignancy, let's say a patient is having a history of breast cancer and coming with a bilateral or there's a mass in the kidney, so we are not sure whether this is actually a kidney cancer or a metastasis from a breast cancer. So in those cases, yes, of course, biopsy is justifiable. If you think a lymphoma, yes, of course, again, biopsy is justifiable. And it has a very good sensitivity and specificity in diagnosing kidney cancers. And one important thing, if we are planning to manage the kidney cancer non-surgically, which I'm going to discuss, you can always consider doing a biopsy to confirm it is a kidney cancer. And there was when we were medical students, there was some doubt about the seeding through this biopsy track, but there are studies done now. The seeding through the biopsy track is minimum. It's somewhere around 0.05%, which is negligible, because we are using a new technique called coaxial technique to take the biopsy from the kidney mass. So the risk of seeding is very less. And then the management of kidney cancer. So when it comes to kidney cancer management, I would first like to talk about the active surveillance. So active surveillance is meant for people who are having small renal masses, because smaller the mass, the chance of being it a benign lesion is high, and also the growth rate of a small renal mass is very less. As you can see, it's just a 0.3 millimeters per year. And also the risk of metastasis is only 1%. So why do we need to go and remove part of the kidney or whole kidney if it is a slow growing, less risk of metastatic tumor? So that's when this active surveillance the concept steps in. So basically, in active surveillance, what we do is we just keep a close eye on the tumor and its growth rate by doing a repeated CT scan, let's say in 6 months time interval. And if it starts to grow, or if it starts to give rise to problem, then only we offer the patient the surgical management. This is mainly important in elderly patients because they might die of something else rather than dying from the kidney cancer, because studies have shown nearly 1/3 of the elderly patients, even though we operate, they will die because of some other reason like stroke or heart attack rather than dying from the kidney cancer. So that's why in elderly we generally consider active surveillance rather than surgical options. Then the question is, what if the patient look like this? So basically, age is just a number. When it comes to management of kidney cancers, we all are considered about the patient's performance status and the fitness. So if it's even if it's an old patient who is fit, or even if or otherwise if it is a young patient, then of course we have to think about the active treatment options. So active treatment options, at your level, you should know about the surgery as well as about something about the ablative techniques. When it comes to surgery, there are two options, either partial nephrectomy or radical nephrectomy. First, I will discuss about that. So why do we need to consider partial nephrectomy? The better term is nephron sparing surgery, because it has shown when we do a partial nephrectomy, we can have the same or comparable overall survival rate as compared to radical nephrectomy. So basically, if we do a partial nephrectomy or radical nephrectomy, the survival rate is same. So why do we need to remove the whole kidney unnecessarily when we can remove a part of the kidney and save the rest? And one other reason is the renal functions. So when we take one kidney out, the chance of getting a renal impairment is high. But when we do a partial nephrectomy, the renal functions will be preserved, more preserved. So that's also beneficial for the patient. And the other thing is, it has shown most of these patients after radical nephrectomy can, if they are going to die, they can die of cardiovascular disorders. So by doing a partial nephrectomy, we can reduce that risk also. So basically the take home message is, if the partial nephrectomy is feasible, technically feasible according to the scoring systems that I discussed before, it is better to go for a partial nephrectomy rather than straight away jump in for a radical nephrectomy, because it has a equal survival outcome with less renal complications as well as cardiovascular complications. All right. Then what are the indications for partial nephrectomy? The guidelines say if the tumor is stage T1, then of course the best management option would be partial nephrectomy. Even for stage 2, if there are absolute indications, you can consider doing partial nephrectomy. For an example, the patient is having only single functioning kidney. So if we remove that kidney, whole kidney, the patient will render anephric. So he will have to go ahead with transplant or dialysis. So in those instances, we have to consider seriously the partial nephrectomy and also the bilateral disease. Again, we can't take the whole both kidneys out. Same result. So because of that, partial nephrectomy is an absolute indication in that instance. And the other thing is, if the contralateral kidney is impaired, and in that case, we tend to consider partial nephrectomy if possible. And if the patient is having hereditary renal cell cancer, so we can consider partial nephrectomy in those patients as well. And the last important point is fitness for surgery, because compared to the radical nephrectomy, partial nephrectomy might be technically challenging, as well as it can cause certain complications like bleeding and all those things. So patient has to be fit to undertake that trauma during the partial nephrectomy. And as I mentioned, the complications of partial nephrectomy or nephron sparing surgery: bleeding, yes, and also urine leak. This urine leak mainly happens when the tumor, that small renal mass, is closer to the collecting system. So we will damage the collecting system during the surgery and it can leak. And there's another important point when we are doing a partial nephrectomy. Remember, there's about 8%, up to 8% chance of getting a positive surgical margin, because we might think macroscopically that we are removing the tumor, but it might have touched the surgical margin. Then what to do? So the tumor recurrence. So we are all worried about tumor recurrence when it comes to positive surgical margin. But the recurrence rates are very less, as you can see. And so if the tumor, what's the rate of tumor recurrence if the positive surgical margin is there, or basically surgical margin is involved? It is about 16% versus 3% if the surgical margin is negative. So basically, if the surgical margin is positive, there's a 16% of chance tumor might come back. But if it is negative, 3% chance. But the best thing is, we don't have to jump and reoperate on these patients just because they are having a positive surgical margin, unlike in other cancers, because the overall survival will not differ. As I very correctly remember, Prof. Neville D. Pereira, my teacher, he was telling even a single cell line of clearance margin is enough if we are planning for a partial nephrectomy, and the statistics or the research confirms it. And even though if there's a tumor recurrence, that's not the end of the world. So obviously we can reconsider doing a redo partial nephrectomy or convert it to a radical nephrectomy, and also tumor ablation, and most importantly, we can do nothing, just active surveillance. And I'll just touch upon the tumor ablation. There are two popular techniques of ablation. One is called cryoablation and the other is called radiofrequency ablation. But one important point I need to highlight is renal mass biopsy is generally required if we are going for ablation. So basically ablation means using these techniques we are going to destroy the tumor, right? So once the tumor is destroyed, we don't have a histological confirmation. Because of that, it is very important, if you are thinking about ablative technique, please do a renal biopsy and confirm it's a cancer and type of the cancer, because we don't know whether it is a papillary cancer, clear cell cancer, likewise. So before ablation, it is important to have a histological diagnosis. And what is the ablative technique that you are going to use? I would say both cryo and radiofrequency ablations are very effective. In cryoablation, basically we cool the tumor and freeze the tumor and kill it. And in radiofrequency ablation, we heat up the tumor and kill it. And only these are the ways of doing it. We can do it percutaneously as well as we can do it laparoscopically. So basically percutaneously or laparoscopically, we insert couple of needles into the tumor. If it is cryoablation, we freeze the tumor, or if it's radiofrequency ablation, we actually heat up the tumor and kill the renal mass or the tumor. So, right. Generally, EAU guideline says tumor ablation can be recommended to frail and comorbid patients with small renal masses, because it is not the best on one to give best. It is not the best one with best oncological outcomes. Because of that, we generally prefer surgery, but if it is an elderly patient, frail patient, lot of comorbidities, why take the risk of going ahead and operating on such a patient? Just go for a ablative technique. There are many ablative techniques coming up, but I think at your level, if you know about cryoablation and radioablation, that's more than enough. What if nephron sparing surgery is not possible, like this kind of a large or huge tumor? Then of course consider radical nephrectomy. So basically that is removal of the kidney within the Gerotas fascia. And generally we consider laparoscopic radical nephrectomy as the standard of care, but our good old open radical nephrectomy is equally effective when it comes to oncological outcomes. Right. So I already told both laparoscopic versus open, same oncological outcome. Now the world is moving forward. Now most of the radical nephrectomies or even partial nephrectomies done in UK and other countries are done robotically. So hopefully in at least a couple of years time, we might get a robot. So it is more effective and technically very comfortable to do a robotic nephrectomy rather than a laparoscopic nephrectomy. So the question about ipsilateral adrenalectomy. The EAU guideline says don't remove the adrenal routinely unless there's radiological evidence of invasion into the adrenal gland, because otherwise it is considered as a T4 tumor, because the kidney is in a separate Gerotas fascia compartment and adrenal is in another compartment. So we can safely leave the adrenal behind if we are going for a radical nephrectomy. And about the lymph node dissection. So basically the take home message is don't do routine lymph node dissections, because there's only less than 20% of the suspected lymph nodes removed during the surgery have harbored the tumor actually. So there's no point of undertaking a huge surgery or long surgery unnecessarily. So if there are any clinical evidence or radiological evidence of enlarged lymph nodes, then of course you can consider lymph node dissection, but otherwise do not, there's no need of routine lymph node dissections during the nephrectomy. And about the adjuvant therapy. So generally, there are a couple of indications for adjuvant therapy, like T3 tumors or T4 tumors. Those are the indications, but at your level, you don't have to remember all these. At least remember one or two indications for adjuvant treatment. And you have to know about these prognostic models or the risk models, because depending on that, we will decide how to follow these patients up. Just remember the name Libovich score, because once we remove the kidney cancer, depending on the histology report, we categorize them into low risk, intermediate risk, and high risk. So depending on risk category, then you are going to see the patient in the clinic and decide on follow-up plan like this. For an example, if it is a high risk, you have to do the CT every 3 monthly initially. But if it is low risk and intermediate risk, you can increase the CT interval to 6 months. Then I'll just touch upon the metastatic RCC. I think I'm already running out of time. So very few things. So when it comes to metastatic RCC, please remember, you just have to categorize patients into 3 categories, whether they are having a good prognostic category, intermediate risk prognostic category, or high risk prognostic category, depending on these parameters. So patient comes with renal cancer, it is metastasis. So now you know, depending on these investigations and criteria, to which category these patients belong to. And then depending on that category, we will decide what to do. So basically, one important point even the medical students should remember is kidney cancers are chemoresistant. So we can't treat them with usual chemotherapy like any other cancer. So we use generally tyrosine kinase inhibitors and immune checkpoint inhibitors to treat kidney cancers. If you know that much, I think that's enough. And then about the management. So I told you there are 3 risk categories depending on the criteria. So if it is good prognosis, we can do something called cytoreductive nephrectomy. This is very unique to the kidney cancers, metastatic kidney cancers, because we are not going to operate on a patient who's having a metastatic rectal cancer or colonic cancer. But even it is metastatized, and if it is good patient belongs to the good prognostic category, still we can offer cytoreductive nephrectomy, because there's a theory called mother satellite theory and the baby satellites, I would say. That theory says that when we remove the kidney, the mother satellite, the baby satellites will die. So there are controversies about this topic, about this theory, but still at your level, I think you can remember like that, because that's why we are offering cytoreductive nephrectomy in a patient with patients who belongs to good prognostic category. But when it comes to intermediate prognosis, there's no point of removing the kidney. It has been proven on research. So first you have to start systemic therapy, either TKIs or immune checkpoint inhibitors, and see the response. If the response is good, if the metastases are dying out, then of course you can consider doing a cytoreductive nephrectomy and see whether it works. Poor prognostic patients, generally we do not offer cytoreductive nephrectomy. We just go ahead with systemic therapy. However, still we can do nephrectomy to symptom palliation. For an example, large tumor causing bleeding and pain. In that case, we can justify taking that kidney out, but generally we do not offer routine cytoreductive nephrectomy in poor prognostic tumors. And these are the trials or the studies from which we came to those conclusions or the management guidelines. And this is just a picture to elaborate it more. These are the mechanism of how these immune checkpoint inhibitors kill the tumor cells. And again, a graphical easy method to remember if it is favorable or good risk, what to do, and poor risk, what to do. So that concludes my presentation. So I'm more than happy to answer any questions. I know it's a long lecture and too much to grasp, but if you have any questions, I would love to answer and clarify any doubts. Thank you. All right, then. If you don't have any questions, I think we can move on to the next discussion. Thank you.
So we'll move on with the next topic, an outline about bladder cancer. So I will try to cover the basics, and whatever the details we can discuss as we go through the case discussion. So in fine details, we'll focus on that. This is just an outline for you to recollect your thoughts about all you know about from your medical student days. So this is the disease burden you could see. It's the 10th mostly common reported cancer. And if you take the male population, it's the 7th. The simple reason we know males are at a higher risk of developing bladder cancer. That is even if you disregard the smoking habits, which is common among males. So the incidence and the mortality, there's a wide variation from region to region and population-wise based on their exposure to risk factors and the accuracy of your diagnostic tools and the practices and access and the services available for healthcare. So if you look at the etiology or the risk factors, the smoking is the leading cause for bladder cancer. In that matter, even the RCC, bladder, upper tract urothelial, smoking is the leading cause. And 50% of the cases, they are smoking related. And we know the bladder cancer being a cancer which is related to chemical carcinogens. Here the smoking also contains a lot of carcinogenic chemicals. And they are filtered through the glomeruli into the kidney, the tubules, and then to the renal pelvic ileal system and the ureter, plus the bladder. So the entire system gets exposed to these carcinogens over a long period. And the duration and intensity of smoking has a direct relationship with the degree of risk. And the second, the interesting part is occupational exposure to chemicals. If you name some of the common chemicals, aromatic amines, polycyclic aromatic hydrocarbons, and chlorinated hydrocarbons. So the hydrocarbons are leading. And which are encountered in certain industries and the occupations. Here you could see related to paint, dye, metal, and the petroleum products and the industry related to that. And there was a new article recently published the highlighting the connection between diesel fume exposure and the risk of bladder cancer. So aging, another risk factor. The commonly we see bladder cancers beyond 50 to 55 years, 90%, but doesn't exclude young people. You could see 10% is less than 55. And obviously the males, they have a higher risk, unfortunately. And this ratio is also changing. Nowadays, we do see quite a number of females presenting with bladder cancer. And among the other risk factors, pelvic radiation and the parasitic infection, schistosomiasis in certain areas where the parasitic infection is prevalent, you could see the slightly higher incidence. And there is this argument always going on about chronic bladder irritation and the metaplasia and squamous cell carcinoma. And about the chronic bladder irritation, there are a lot of hypotheses, and long-standing bladder stones over 10, 15 years is one culprit, and there's always a controversy. So if you look at these factors, there is a limited exposure impact or the doubtful significance. One is environmental exposure. And there are certain papers to show there's a slight link between chlorinated, the drinking water, and also arsenic in drinking water and the bladder cancer, but it's small numbers and the small studies. And the genetics, of course, limited impact as compared to RCC, where you have a larger proportion of patients having a positive or the genetically predisposed to cancers, whereas the bladder cancer, the genetic familial predisposition is quite small and not very significant. And the dietary habits, more than you can point out a particular diet which could expose to bladder cancer, there are papers to show the healthy diet, for example, diet rich in fresh vegetables and fruits and low meat, red meat, and then there is a slight protection against bladder cancer. And then there are metabolic factors. The metabolic syndrome, body mass index, blood pressure, glucose, and if they are present along with other risk factors, then you have a slightly higher chance. So these are limited factors as opposed to the strong risk factors which I have mentioned earlier. About tumor staging at your level, I would say you need to focus on non-muscle invasive disease because there is a clear-cut difference in management, and the muscle invasive disease where the detrusor muscle is invaded and there is a sub-classification T2AB, T3AB. You don't have to know that much at your level. And then we have the locally advanced disease, which is coming out of the bladder and invading the neighboring structures, pelvic, maybe the prostate, urethra, and then you have the lateral pelvic walls, bones, and all these things in the vicinity. And obviously beyond this, you have the metastatic disease. The newer TMN classification, remember, the nodal metastasis is considered the nodes in the true pelvis. The nodes beyond that, that is paraiotic nodes, are considered as metastasis rather than the nodal. The paraiotic nodes are considered M1. Another special word about carcinoma in situ, as I mentioned in the earlier presentation, as opposed to other cancers, the bladder cancer carcinoma in situ will carry a higher risk and the poor prognosis. This is an intraepithelial, high-grade, non-invasive urothelial cancer. One of the initial stages, you could see the slide on top, the picture on top. But this is very bad sign. If it is present, maybe with another full-blown cancer, that is a bad prognostic sign. About tumor grading, which has changed over a time, you could see the initial 1973 WHO grading, which graded grade 1, 2, 3. Which was later changed to WHO 2004 to 22 grading, where we talk about PUN lump, where the papillary urothelial neoplasm of low malignant potential. That is grade 1 divided into 2. And then you have the low grade and the high grade. That is the modern classification that we use. But however, still both classifications are used in histological reports you may come across, depending on the pathologist that who's reporting at your center. The combination of both could be still seen. So this the hematuria being the commonest presentation, and the other presenting features are LUTs. Mainly you are looking at irritative LUTs, and now we see quite a number of lesions incidentally detected in a scan done for some other purpose. And there are rare other presentations such as passage of fleshy particles, and then if it is advanced cancer, patient may present with a mass, very extremely rare presentation nowadays. And sometimes you can see the enterovesical fistula, where they present with the fecal urea and haematuria, again rare. So when it comes to diagnosis, the imaging is mainly, if you do a CT urogram, the contrast study, the late films, you could see there's a filling defect and maybe the focal bladder wall thickening. If it is a muscle invasive cancer, there is always there is a chance you get hydronephrosis. So in the presence of a bladder cancer, if you detect hydronephrosis and hydroureter, that is muscle invasive disease unless proven otherwise. That you need to remember. The other advantages of CT urogram, you could screen the upper tracts, looking for synchronous lesions. Again, the incidence is variable. It's 1.8 to 7.5%, especially if the tumor, the primary tumor located in and around the trigonal area in the bladder, there's a slightly higher chance of getting a synchronous lesion in the upper tracts. And the same CT, you can use it for tumor staging, where you can look at the paraiotic nodes and the liver, whatever all the other structures, you can use it for staging purposes. Lung metastasis is less common in bladder cancer. Therefore, routinely we don't do CT chest unless we have a clue to suspect it's advanced cancer and there are lung metastases. The role of MRI, which is coming up these days, one of the hot topics if you attend most of the international meetings, where the MRI, of course, in our setup, we have a limited access, but other countries, they have a easy access to MRI. Like prostate, the important role of MRI in particularly the localized bladder cancer is really coming up. The like PIRAD scoring system in prostate cancer, here VRADS you have. That is vesicle imaging reporting and data system, which will predict the possibility or the probability of muscle invasion based on a properly conduct multiparametric MRI pelvis. The ultrasound scan, of course, limited sun sensitivity. And you may detect intraluminal masses, especially if you do with a full bladder with an experienced radiologist. But there's always a chance you can easily miss early flat lesions. In that case, even your CT will not replace the role of cystoscopy. The cytology, the sensitivity is high when it comes to high-grade tumors, about 84%. However, low-grade tumors, sensitivity is very low, therefore not very reliable. If you have a positive cytology, yes, that indicates whether there's a urothelial tumor, either bladder or the upper tract, but the negative cytology will not exclude the presence of a tumor. In the case of CIS, it's a variable sensitivity in the range of 28 to 100%. The urinary molecular markers, the role is very limited, only confined to the studies and the research level, which are not in routine clinical practice. They never still yet to appear in routine clinical guidelines. So I have not mentioned here at your level. The cystoscopy is the investigation of choice, where you directly visualize the tumor. Commonly we perform flexible cystoscopy when they present with haematuria, which is a local anesthetic procedure, topical anesthesia. The possibilities, you may detect an obvious lesion as indicated in the top, where the papillary lesion, like frond-like, coral-like lesion, you know definitely it's a tumor. It's the urothelial tumor. On the other hand, the second one I have shown a solid lesion. If you compare the papillary lesion and the solid lesion, of course, the prognosis is worse with the solid lesion. The invasion, the aggressiveness, and the prognosis is worse with solid lesions. And the bottom one, red patches are there, which could be inflammatory or which could indicate underlying carcinoma in situ. So if you see an obvious lesion during cystoscopy, routinely we don't perform any cold cup biopsies. Now, for example, if you do a colonoscopy or upper GI endoscopy, if you see a lesion, you tend to take a biopsy and confirm with histology. But if it is obvious obvious bladder tumor, routine biopsies are not indicated at this point, because this is not going to change your subsequent management. But of course, if you see a red lesion like the bottom one, if you are not quite sure whether you are dealing with a inflammatory lesion or whether something neoplastic, maybe you would consider doing a biopsy. So if it is a neoplastic lesion, you can proceed with your further management. So if you see a lesion, what is the next step? You need to proceed with your transurethral resection. That is the biopsy process. It will eliminate the obvious macroscopic tumor. You need to resect the macroscopic tumor completely, and you can obtain the sample for histology. So the pathological diagnosis, staging, and you establish based on your histology, and you completely remove the visible lesions. And this is in fact the most crucial procedure in the management of bladder cancer. The quality of your TURBT will determine subsequent management. I will show you in my next slide. And when you do the resection, you are supposed to resect the macroscopic tumor. as well as you need to take deep biopsies from the tumor base. The tumor-based biopsies will confirm whether the tumor is invading the muscle or not, which is very important for your subsequent management. So if you do a good TURBT, you can identify the risk factors required to assign the disease risk, where the tumor size, you need to tell exactly in your diagram, because when you do the TURBT, we make a diagram and indicate in the diagram, and the tumor size, because size, whether it's 3.5 centimeters or less, that makes a difference. That way you will decide whether to give intravesical treatment afterwards based on the size also. Then the architecture, whether it's papillary, solid papillary, what is the location, whether trigonal lesion or the dome, and concerns for any CIS, coexisting CIS, whether it's a recurrent tumor or primary tumor, all these things which are important. And the clinical stage, of course, in the presence of modern era, we have good the imaging techniques. They are for the bimanual palpation and trying to identify the tumor. Stage is very limited nowadays. You rely on your imaging techniques mostly. And the adequacy of your resection, which will evaluate the resection quality. Number one, you need to completely resect all the macroscopic tumor, and your sample should contain the detrusor muscle for your pathologist to evaluate. If the sample shows no detrusor muscle, that means you need to re-resect the tumor base. So traditionally we used to do piecemeal resection. We keep on resecting the tumor piece by piece, and then finally we end up with the tumor base. As opposed to traditional piecemeal resection, we have now the en-bloc resection, where small tumors, you mark the tumor base, along with the tumor base, you resect the entire lesion in one piece and try to retrieve. The issue is the size of the tumor. If it is a too big, large tumor, obviously you can't take it out through the cystoscope, through the urethra. But small lesions, then you take out as one piece through the urethra. The en-bloc resection you could do with the cystoscopy diathermy or even the laser. The laser techniques are very popular nowadays for en-bloc resection. Piecemeal resection, we used to call it oncological surgical madness, because any tumor, you are not supposed to cut through the tumor and you try to take as one piece. But as opposed to any other tumor, you keep on chopping the tumor and you disperse tumor cells all over the bladder, and which is a mad procedure, but for the obvious reasons. So what are we going to do? When the tumor is dispersed, tumor cells are dispersed throughout the bladder during the surgery, how can you get rid of the tumors? There is always a theoretical potential risk. These cells can deposit elsewhere in the bladder urothelium and give rise to another tumor. One is when during the surgery you keep on irrigating the bladder, you can wash out the bladder. That's important. And even post-operatively, for a short period, you will irrigate the bladder. That's important. The second thing, all these patients, they will need immediate instillation of intravesical chemotherapy. Mitomycin C, single dose. That will destroy, mop out all the floating tumor cells in the bladder. As soon as you achieve hemostasis, no longer you need irrigation. Earlier the better. The best results you can achieve within 6 hours. But up to 24 hours you can try. You, through the catheter itself, you introduce the MMC, keep the catheter clamped. You turn the patient this way and that way to immerse the entire bladder with chemotherapy. And you drain the chemotherapy after a couple of hours, and then you remove the catheter. That is the procedure. But remember, there are contraindications. For example, during the surgery, if you happen to perforate the bladder, that is a contraindication where you can't give chemotherapy immediately, because that will extravasate from the bladder and then cause a lot of irritation and pain, and which is toxic. On the other hand, if you struggle to achieve hemostasis, and obviously if you need to continue irrigation for a longer period, then you can't, since you need to continue irrigation, no point putting a chemotherapy into the bladder. Those are some of the contraindications. And if you look at tumor visualization, we have the conventional white light. That is what we routinely used in this country. But the detection rates are much higher if you use photodynamic diagnosis as well as narrowband imaging. Where the early cancers, the flat lesions can be accurately identified. You can map out the lesions well with these advanced techniques, which are used in initial cystoscopy diagnosis as well as resection, and also during the cystoscopic surveillance to identify early recurrences. So once you complete your TURB, the histological confirmation, grading, and we do restaging. And histologically, you divide them into two categories, urothelial cancers and the non-urothelial cancers, where you have squamous, usually due to the pathway, the chronic irritation, and squamous metaplasia and squamous carcinoma. And you have primary adenocarcinoma. Again, we have two varieties. We know the urachal cyst, the embryological remnant, which could develop into urachal cyst carcinoma, and typically you see in young people in the bladder dome, where originally the urachal cyst attached to the bladder. As opposed to that, we do have another entity, primary adenocarcinoma of the bladder, which is not of urachal origin. Then other rare varieties such as sarcomas, lymphomas, melanomas, and remember metastasis, and also the tumors locally advancing into the bladder, commonly from the prostate and the gut, the colon, rectum, and also in females, don't miss out the gynecological malignancies, ovarian and the endometrial. They can invade into the bladder, and the cervical, very common. Cervical cancers are pretty common to invade into the bladder. In fact, if you see a patient bilateral hydronephrosis, hydroureter, and if it is not due to any high pressure chronic retention, in males, think about prostate CA invading the bladder, the trigonal area. In females, always think about cervical carcinoma invading the trigone of the bladder area. So that's important. You need to focus on these two. Once you get the histological confirmation and you restage the tumor, because obviously you have the muscle sample in your specimen, your pathologist will tell whether the tumor is invading the underlying muscle layer, the detrusor muscle. So based on that, if the tumor is confined to the bladder, it's important you differentiate whether it's a non-muscle invasive bladder cancer or whether it's a muscle invasive bladder cancer, because the management is totally different. So non-muscle invasive bladder cancer, what is the role of re-resection? If you go through all the standard guidelines, they clearly mention re-resection, second resection, usually 2 to 6 weeks after the initial TURB, and repeat histological re-evaluation. It's important. If you know there are residual tumors after initial resection, for some reason, if you stop halfway through, then obviously you need to go in and do a re-resection to complete the resection. The second thing, if you get a sample without any muscle containing in the specimen, then you need to go ahead and take another sample from the tumor base to include the muscle. The third one, if your initial histology is high-grade disease, high-grade non-muscle invasive, definitely there is a place for re-resection, because about up to 20% of these high-grade non-muscle invasive bladder cancers, they upstage after your second resection. They can become muscle invasive, because high-grade and non-muscle invasive, usually they don't go together. Therefore, always according to the guidelines, you need to offer re-resection to these patients. So once you confirm if it is a non-muscle invasive bladder cancer, after even a second resection, if it is indicated, you divide them into 3 categories based on the risk stratification. That is a bit of an advanced thing we will not discuss at this level, but of course, when we talk about the cases, probably you will come across. Low risk disease, if the risk of recurrence is less, the invasion progression is less, you keep the patients under cystoscopic surveillance. There are different protocols depending on where you practice, how frequently you need to arrange cystoscopy. For the convenience in this country, we initially do every 3 months, and subsequently we proceed with 6 months, 1 year annually. If it is a low grade, low risk, you terminate after 5 years, but certain patients, you may consider continuing cystoscopic surveillance lifelong, especially intermediate and high risk patients. And certain intermediate risk group, then you have the intravesical chemotherapy, mitomycin C, which is the commonly used agent. where you need to give 6 cycles intravesical. I'm referring not to the initial one, which I mentioned immediately after URBT. This is subsequently after the histology, you need to give 6 cycles. Plus, obviously, you need to keep them under cystoscopic surveillance. And then you have intravesical BCG, which is much superior to your mitomycin C. And you will consider giving BCG certain high-risk patients who are at high risk of developing the tumor recurrence and progression. So if you look at mitomycin C, which is known to reduce the frequency of tumor recurrence, but there is no effect on disease progression with MMC. As opposed to BCG, that is proven to reduce the tumor progression and also reduce the incidence of recurrence. So your BCG is much more superior than MMC. I re-stress. When it comes to BCG, usually you don't immediately give BCG after your TURB because the BCG is very toxic. If you try to give with the row surface in the bladder initial first 2 weeks or 3-4 weeks, and there's a chance with the rare complications such as the liver toxicity and so on. Therefore, we tend to delay BCG usually 4 to 6 weeks and beyond. The BCG is a long cycle to get the benefit, initial induction, 6 cycles, and then you get into the maintenance. There are different protocols every 3 months, 6 months. So there's a protocol and minimum 2 years of BCG or maybe up to 3 years. That is the duration of BCG treatment. But the problem of BCG, obviously, the side effects are much higher. And a lot of people, they experience bladder irritation and then overactive bladder symptoms. They find it very difficult to tolerate BCG. It's a very common scenario. So you need to prepare your patient well in advance to get the best compliance. There are different theories how the BCG is effective against bladder tumor cells. Still, it's updating. And some of the theories are direct BCG toxicity against the tumor cells and then the immune-mediated mechanisms. You could see the innate and the adaptive immune response. Some of the innate immune response, it's basically cytokine-mediated, whereas the adaptive immune reaction through the mechanisms as I shown down here. So what is the management of the bladder, muscle invasive bladder cancer? What is so special about muscle invasive disease? The problem is when it is muscle invasive at a focal point, when it invades the muscle, detrusor muscle has a very rich lymphatic supply, lymphatic network within the muscle. So when it enters from one focal point into the muscle, basically your entire bladder is involved with the tumor. You never know where it will end up. So whatever your treatment, you should target the entire bladder and full thickness. That is the principle. So the treatment options available, either radical radiotherapy, you irradiate the entire bladder, or you need to offer radical cystectomy. Surgically, you remove the entire bladder along with the pelvic nodes. And when you remove the bladder, you need to establish the continuity of the urinary tract. You have 2 options. The best would be neobladder, where you can form and formulate a bladder. Commonly out of bowel, we use the large bowel as well as a small bowel. There are different configurations and different the neobladders we perform. The other one, we have the urinary diversion. Commonly used is ileal conduit urinary diversion, where your patient will end up with a urostomy, where the lifelong bag attached to collect urine. So obviously the quality of life is much better with neobladders, but of course there are contraindications. For example, if the disease is involved in the trigonal area and the urethral involvement, the prostatic urethra, the neobladders are contraindicated, and obviously you are left with urinary diversion. And their baseline kidney function also a determining factor when it comes to neobladders. If it is advanced disease, metastatic disease, the tumor control you achieve with systemic chemotherapy, and then you have the full array of your palliative options available to control the symptoms and their complications. The common ones encounter, one is upper tract obstruction. The ureters easily get obstructed with the muscle invasive disease, and the retrograde stenting sometimes difficult because you can't identify the ureteric orifices through the cystoscope. In that matter, you are left with percutaneous nephrostomy. Your interventional radiologist will help you to have a nephrostomy. And if they are smart enough, sometimes they'll be able to get an antegrade stenting from starting from the kidney downwards, pushing into the bladder, which is much better than a nephrostomy. But there's always a risk, even your stent can get blocked with the bladder tumor progression. And these people, they can have recurrent hematuria and clot retention, which is a bothersome thing. Keep on getting them to admit and go out, in, out hospitals. And advanced tumors, when they involve the sacral plexus, the lateral pelvic walls, and they start developing severe bladder pain, then you need to think about all the pain management protocols and the procedures. And advanced diseases with the fistula, then think about the diversions, and then there are other symptoms you need to palliate. Locally advanced disease obviously depends on the extent of the disease and the individual factors. Sometimes you may decide to give pelvic radiotherapy, and even the surgical resection still feasible for locally advanced disease, and we may consider pelvic excenteration and the diversions along with the part of the rectum, or maybe in females anyway you sacrifice the uterus and the ovaries. When it comes to radical cystectomy, we perform usually anterior pelvic excenteration. And systemic chemotherapy, still there may be a place, and then your symptom management and the complication management, which has a role. So in summary, bladder cancer is common, but the demography is changing. We do see quite a number of young patients as well as females presenting with bladder cancer nowadays. Hematuria is a leading cause. Smoking is the main risk factor you need to identify. And your initial TURB is the most important, crucial decision-making procedure that you need to remember. So the quality of your TURB is very important. And the presence of histologically proven muscle invasion will change your management approach to the disease in the bladder cancer. So that is all about bladder cancer in a nutshell, very summarized version. But of course, a lot of complicated issues will arise when we discuss cases you will come across. This is not as simple as this. A lot of gray areas and a lot of arguments. So feel free, any questions from the audience, I'm happy to answer. Or you can keep all the questions from the eminent panel during the tea break, you can ask. Any questions so far? Any from the regional centers, any questions? We can see Candy, Betty, Jaffna. Okay, in the absence of questions, we'll stop here now. The time is sharp it's sharp 10, so we will break for a small tea break, and we will come back by 10:15 for the case discussion. There are some interesting cases. I'm sure that will be more interesting one than these traditional lectures. Will be more mutually beneficial, and we will also learn from you, and very interesting. So we'll look forward to case discussion. So we'll break for now, and we'll come back by 10:15. I have to run around the entire hall. Anyway, I'm coming down. Nirosh, you run the slide Mangal Herald. Okay, we are back here. Anuradhapura, Jaffna, Betty, Candy, Pera, we are back here now. We are about to start the case discussion. We have lined up few cases to elaborate more on the theory part and also to clear your doubts during the question time. So feel free. I would like to hear from the regional centers. Please participate. We expect active participation from all the participants. And the panelists here, we have Professor Neville Pereira and Professor Dr. Manjul Vijayavardhana and Dr. Niroshan Kodikari and myself. We are moderating and also we'll be contributing. So we'll start with the Haematuria case and I'll pass it to Niroshan to take you through the question.
Right, this is the first case. So it's a 65 years old male patient presented with intermittent hematuria. He was recently started on rivaroxaban for atrial fibrillation and claims hematuria was noted after starting the rivaroxaban. On his past medical history, he's a smoker with 10 pack years history. And we did the basic investigations, which includes UFR. It shows 300 RBCs. And
we'll stop at that point, Niroshan. Okay, so far, what are your thoughts about this case?
This patient is having a visible hematuria, even though there is obvious risk factors for the hematuria, such as stone as well as he's on rivaroxaban ban. But considering his age, I would like to exclude other possible causes. So to exclude that, I would like to go ahead with the flexible cystoscopy as well.
Okay, is it only the age? Anything else?
Yes, yeah.
Smoking risk factor. That's important, right? And
Yeah, let's say now the GP has correctly done the NCCT KUB, which shows 8 mm stone in the lower calyx of left kidney without any obstruction.
okay, what do you think about that NCCT report? For number one, I want to know the applicability or the suitability of the CT and also the comments given in the CT.
Actually, it's there's a 8 mm non-obstructive part. NCCT as an initial investigations, we can consider it as something he has done correctly. But basically, in case of this patient, as 65 years old, being a male, as well as with visible hematuria, with the history of smoking itself, NCCT might not enough to come for a conclusion. But itself, this stone, according to the position as well as its non-obstructive part, the reason for the hematuria might be this stone, but it's not for us to stop there.
From the panel now, it says no mass lesions in the NCCT KUB. What do you think, sir? What are your inputs about that?
Important point there in NCCT is that it is done usually for stones. But when it comes to tumors, non-contrast CT sensitivity is pretty low. And bladder mass, especially no mass lesions means...
Probably they are referring to
kidney
renal
mass
masses, yeah.
lesions. It's very difficult because you diagnose a tumor in a contrast enhanced, and when you enhance the images, if there is a difference of Hounsfield, 15 Hounsfield units, you know the density is measured in Hounsfields. In a soft tissue, there's a 15 Hounsfield unit difference, then only you consider that as a mass tumor. Because if it is less than that, it could be a pseudotumor or maybe a embryological difference like fetal lobulation, or sometimes you get this dromedary hump on the left side when the spleen compresses the kidney. It looks like a little lump. So
and column of Bertini also.
Column of Bertini as well. That is a prominent papilla. A prominent papilla can look like a mass. So those days we had to do DTPA scan or DMSA to differentiate it. But now contrast enhanced CT, if there is this Hounsfield difference, we can diagnose it. So, but NCCT is something you should not take as the final word.
Yeah. And at the same time, can I just bring out the focus on this painful hematuria and painless hematuria? Is there any values to differentiate this and then trying to look at the differential diagnosis? Will it change your management?
Yes. First, the definition. First, the definition of painless hematuria is important. Because if you get a headache and then hematuria, that's not painful hematuria.
And so commonly it's dysuria and hematuria. A lot of people, they misinterpret.
That's right. So it is a lower urinary tract symptoms associated with hematuria, especially then it's or pain. That is called painful. So even a renal colic and hematuria may not fall into the true category of painful hematuria. Why are we trying to sort of identify this? Is that painless is generally considered in the past as non-malignant, painful, and painless malignant. But there are pitfalls because even carcinoma in situ, leading to what we call malignant carcinoma in situ, involved in the whole, it's called malignant cystitis, involving the whole urothelium, can lead to pain and dysuria and low urinary tract symptoms. And also, there can be a bladder cancer which is necrotizing, which is dying and then getting infected. The dead part can get infected and you can end up in infection-like symptoms. So that painless, painful thing is not that significant when it comes to it.
And the other thing, don't forget the clot colics. Even in fact, right now itself, I have a patient, elderly lady with a known patient now with a renal mass, came to ward with a typical ureteric colic, and she's passing small clots, and every time she passes a clot, she gets severe pain, typical ureteric colic. So this demarcation between painful, painless hematuria is not really valid in clinical setup, whether it's painful or painless. And sometimes the stones could be silent. There are stones, ureteric stones, but no pain. It's just hematuria, painless hematuria. So there is no real value differentiating. Irrespective whether it's painful or painless, you need to investigate fully. That is a take-home message. Anything to add, sir?
Yes, in fact, it's been recommended that even if you are having UTI, it's a positive pyuria and there is UTI, still anybody over the age of 45, it is better to investigate in the line of hematuria rather than just treating the infection and closing the chapter.
Because infective bladder cancers, always you can see pyuria appearing in addition to hematuria in the sample. So never attribute it to just a simple infection as such.
So, Ranga, shall we make it, if it's a visible hematuria, then of course, all your investigation and assessment is valid.
Yes.
So that will be a, a less confusing method.
Yeah.
All right. What is the next step of management in this patient?
We all learn from each other.
So I would like to do a contrast CTIVU and a cystoscopy.
Okay. Right.
Okay, we all agree the contrast study, contrast CT urogram, and then we'll be doing a flexible cystoscopy for the evaluation, for the completeness. So yeah, we can see.
Well,
Yeah, before
during-
that, can I just raise another question? Now say this particular patient, you do all the investigations. You do the CT urogram, you do the flexible cystoscopy, both are negative. But patient is repeatedly coming, maybe another 2 weeks, 3 weeks, another month later, coming with unexplained hematuria. What are we going to do? Any ideas, anything you want to mention?
Then of course, Ranga, now we are thinking of some cause in bleed that is most probably in the kidneys. So maybe in that flexible cystoscopy or the cystoscopy under anesthesia, one can watch the ureteric orifices to see whether you can lateralize the bleed. Because this repeated bleeding with nothing either could be prostatic or upper tract. So if the cystoscopy is repeated or on the first time, you can notice the blood urinary water jet is showing bloodstained urine. Then of course you can suspect some arteriovenous malformation or a fistula or some congenital abnormality in the vascular system connecting with the pelvic ileus system. In that case, of course, I think we have to advance the CT study further.
Yeah, it's a very valid point. As I mentioned, one is it's prostate. Prostate is very common to give rise to repeated bleeding and the upper tract bleeding. So you need to focus those two. And the other additional thing I wanted to ask, this came into my mind.
I think the points to one thing is that especially if he is in renal failure, can't do CTI view.
Yes.
So what should we do thereafter?
We will ask the audience.
Okay.
We'll see, get some opinions.
Since the patient is having CK disease, given contrast is a contraindication. So I will go ahead with the flexible cystoscopy, where I will visualize the whole of the bladder and the ureteral orifices. Simultaneously, I can appreciate the level of the urethra, the prostate, and the verumontanum as well. So the lower tract will be defining by the flexible cystoscopy, and other option will be a non-contrast MRI in the lip.
Any other different answers? How are we going to screen the upper tract? Any idea?
URS is also a possibility additional to the above previous indicated.
Right, ureteroscopy, we have two types. We have the semi-rigid, you could reach up to the renal pelvis, and then you have the flexible ureteroscopy. If you are in the best center, all the facilities, what would you select?
Flexible URS.
Yes, the reason you can get into the calyces and visualize the calyces also. And plus, I'm sure the Niroshan would agree, and all the UK centers, and we combine this with a retrograde study. We inject contrast while doing ureteroscopy, so you can fill the entire renal pelvic calcium system with contrast to see whether there are any abnormal filling defects in the system, in addition to direct visualization. Anything to add, sir?
Yes,
Ranga, other thing
sometimes
is that
the upper tract tumors were suspected, but how to diagnose? If even if the CTIV is negative, still if the urine cytology is positive, because urine cytology is something you can do with the midday urine sample. It's not early morning urine sample, right? Midday total urine sample, you check for cytology. And cytology is generally positive, as it was mentioned in the lecture, when there is undifferentiated tumors. So that is positive. Then, of course, you do uteroscopy and sometimes brush biopsies. Then nowadays, of course, when the flexible URS is there, that will be the final answer for unanswered hematuria.
And one question, sir, mention not the early morning sample, probably the midday sample. Any thoughts about it? Why? Why do you think? Yes, yes.
In the early morning sample, you have a concentrated urine. Yeah, and
Yeah, basically, it's collected urine in the bladder, and then you are getting the sample. Ideally, it has to be a fresh sample. And what is the volume that you want to send? The urine sample for cytology, what is the volume you want to send? Minimum? Yeah, minimum you need to have at least 50 milliliters or more. Because what you do is you send the sample, centrifuge, you get the cells separated, and then you try to examine under the microscope. It has to be an adequate sample. Small urine sample like you collect for UFR or culture, that is not going to be helpful. Number one. Number two, you can increase the yield or the sensitivity of your cytology, as sir mentioned, while doing the ureteroscopy. You can give good washout to the renal pelvic calyceal system through the ureteroscope itself. You can aspirate the sample and send it. That will have a better sensitivity than just randomly collecting a urine sample for cytology. That's another thing to add upon to this.
And I would.
Ranga, I'm Dr. Manjula Hirath from Kandy.
Yes, sir.
Hello?
Yes, please, sir.
Yeah, the one thing that I think that at the initial workup, they have not done ultrasound scan. So I think as a GP, best things to go, rather than jumping into non-contrast CT, the ultrasound scan would be the initial assessment of hematuria. And second thing, because this patient is having CKD, good quality ultrasound scan help more than NCCT KUP to assess upper tract tumors.
Correct.
I mean, the evidence of renal tumor as well as evidence of possible evidence because hydronephrosis may be due to upper tract disease, especially patient with CKD. Yeah, we can't give contrast. That might add additional information at the beginning.
Yes, and the
To
ultrasound
add
scan,
to,
obviously, the
sorry,
quality depends on the experience of the
Yeah,
radiologist,
good
and
quality one.
also the machine matters, the instrument
yeah.
that you
Can,
use.
can I add to that? Tilina.
Yes, Tirina, go ahead, please.
Yeah. So to add to that, now in other centers, especially for the question of patients who are having renal failure, contrast enhanced ultrasound is also coming up in a big way, especially in developed countries, as a kind of substitute when we can't do the CT IVPs and contrast MRI. So that's something they use bubbles. So it's not a contrast that they're using. They use agitated bubbles for enhancement during ultrasound scan. But of course, it's
Yeah, I
not
was
available
about to
in
ask
our
that
country.
question about the
Sorry.
contrast. You have given the answer, Tirina. Yeah, please continue.
Yeah, so sorry, I didn't actually know that. So yeah, so that's something to consider because it's in patients with renal failure that's a good second line investigation.
So do we have
No
ultrasound?
contrast enhanced. I mean, it's coming up, as you know, CSU it's called, So, but I think it should made available. It increased
Yeah.
the sensitivity, but only problem is the bladder will be completely, unless there is a big tumor, say over 1 centimeter or so, exophytic tumor, flat tumors and CIS will be, carcinoma inside will be completely missed in ultrasound.
So basically, it's a
Yes.
upper tracks, I think.
Upper tracks, yeah.
When it
Good
comes to
option,
upper tract, I think ultrasound is the first, I think should be the first line and most accessible investigation.
Yeah, whatever said, and that is a mostly widely available investigation of choice available.
Yes.
Ranga, before Manjula from Candidate, I was going to point out, yeah, somebody said flexible URS. So all this URS, although we are not doing properly, initially there is a retrograde pyelogram phase.
Yes.
So you can direct your scoping to whatever the suspicious area on your retrograde study. Suppose you get one KLEC is not filling up or a concave, no, convex SOL, because that flexi URS, it's like going into an ocean when you're in the renal pelvis. You don't know where you are looking for. So if you can get some information on the retrograde pyelogram and then zero on it. But the thing is, this contrast into the lumina is not a problem for the CKD.
Not a problem in CKD. It's the contrast which is filtered through the kidney which is a problem. So this is perfectly okay.
And I would like to add to that scenario Neville sir was talking about, like all the upper tract images were normal, flexible cystoscopy was also normal. But if the patient is still continue to have hematuria, as correctly suggested, urine cytology is an option. And to add something to your answer, you said like it's not early morning sample. The reason is the cytolysis, the destruction of the cells is highest during the early morning sample. That's why we are taking the midday sample. And also there's a place for early morning sample, especially in Sri Lanka, because we have to think about the TB infection. So we can send early morning urine for TB site, TB staining to exclude that. And also midday whole urine for cytology. And then depending on that, we can decide on biopsy under anesthesia. That is also one option. Yeah.
How do you differentiate hematuria of nephrological origin? Maybe the glomerular nephritis or the leaking from the kidney from the urological causes? Clinically?
Patient is having hypertension, as well as the if patient is having edema and the reduced urine output, and we can analyze the urine for the presence of the albumin proteinuria. And, yes.
Yes, red cell cast, another one, and one more. Yes. Dysmorphic red cells, that's important. That's how you differentiate.
And the age is very important.
Age is very important.
Yeah, because it generally happens in younger patients, less than 40 years of age. Always think about nephritic cause rather than an anatomical or tumor. Shall I move on to the?
Yes, we'll move on.
Yeah. So case 2. So 76 years old female presents with an ultrasound scan finding of an incidentally detected lesion in her right kidney measuring 3.5 centimeters. So what are the salient points that you are going to ask in the history?
So we want to know what her symptoms are. This basically says that she is asymptomatic. But I would ask her if she has any features of paraneoplastic syndrome or any features of metastasis, if it has not been asked. Based on the ultrasound, it's a small renal mass, but I would want to confirm it by doing a triple phase CT along with a CTI view. And the other thing to consider is her fitness for surgery, because she's 76, and what her medical comorbidities are, because that might, I'll have to take that into consideration with regards to my management.
Anything else? Rather than imaging, any basic investigations you are going to do in this patient?
Yeah, I'll do a UFR to see if there's hematuria.
Okay.
And also I'll do a renal function test to check the creatinine.
Yeah, I think renal function tests are more important than UFR, because by doing UFR, you are not going to gain anything because there's obvious lesion, right? So renal functions are very important in deciding, because she is 76 years old. Yeah.
Ranga, would you ask about any symptoms of metastasis when the lesion is less than?
That's the question. Now the lesion is 3.5 centimeter. Well, for the completeness, you can ask what is the chance that she is having METs due to this? Let's say it's RCC, 3.5 centimeter. What is the chance of having METs? Any idea?
It is less than 5%. It's very low.
Yeah, it's actually, I told 1.5 to 8% chance of having METs very low. Yeah.
That is one of the rationales for this non-operative or the conservative approach for the small masses.
So that leaves some other vital questions in the history with regards to the etiological factors. So that would have been important in the history. When you notice this in the ultrasound scan, so what would those questions be?
Whether the patient has a family history of renal cell malignancies, whether there is a family history of any hereditary syndrome such as von Hippel-Lindau syndrome, and also although it's a female, smoking history and exposure to chemical and those are the etiological factors. Part of obesity, we can measure the BMI. Apart from that, we can go through the detailed history of the symptomatology, whether although she's asymptomatic, and yeah, the paraneoplastic features, whether there are any paraneoplastic features such as hypercalcemia, anemia, and thrombocytosis. So, yeah.
Now you mentioned the family history. I totally agree. But what do you think? What is the chance that she's having a familial cancer? What do you think? What is anything classical about familial RCC? She's 76. Who will get familial? What are the features of familial cancer?
Usually getting in the young age. The familial VHL gene will be affected.
Yes, it's younger age, early onset, bilateral, the multifocal. So those are the other things to look into.
Right. Okay, then what is the next line of investigation?
Somebody already mentioned, isn't it?
Yeah, it's triple phase CT IVU.
So what do you mean by triple phase? Triphasic CT with the delayed phase IVU phase.
Initially the non-contrast, and then 20 to 40 seconds, and then the late phase.
The name of the
Arterial.
Arterial or corticomedullary, correct? Yeah.
And then the washout phase.
Yes, it is
90
called
seconds.
yes, a nephrogenic phase. Yeah, that is the ideal non-contrast. Triple phase CT. But you can always add the delayed phase after like 10 minutes. It will exclude any filling defects and the upper tract tumors and the bladder tumors. Not exclude, I mean, yeah. Delayed phase is to exclude any transitional cell tumors in the collecting system. But if you really focus on the renal tumor, renal mass, the triphasic, non-contrast, corticomedullary, and nephrogenic phase is enough.
Yeah. They are done at 30 seconds and 100 seconds. 0 is the non-contrast, then 30 seconds and 100 seconds. 30 seconds, vessels will be filled up with dye. 100 seconds, the tubules will be filled up with dye. And if you take a late film, 5 minutes, then you will need the excretory phase. You will see the filling defects and all these calyceal distortions and things like that. So that is triple phase for kidney cancers, breast. That's another additional phase, delayed phase.
Yes.
Now, rather than wasting 2 episodes of CT scan for this patient, can you also ask for a angiogram with the same thing?
Yes, we can during the arterial phase, we can get the angiogram at the same time. And actually now they have like a new technique to reduce the radiation exposure further. It's called split bolus techniques. So rather than like waiting for 100 seconds, we give the contrast and take the shot, and then after like 50 seconds, we can repeat 2 films and then combine it and then come to that. Please read about that technique if you are really interested. That is called split bolus technique, which will reduce the number of exposures.
Yeah.
And what is the importance of knowing the vascular pattern, the angiographic picture in this case?
You are reading my mind. Actually, there are a lot of people just ask for CT, urography or triple phase CT, but then they forget to ask about the vascular phase. So we have to send the CD recording back to the radiologist and ask them to print the vascular phase. Because it's important for us, especially when you are doing nephron sparing surgery, because there are some aberrant arteries. Sometimes the renal artery divides far away or sometimes early, and then you get extra arteries coming straight away from the aorta. So when you are going for nephron sparing, all this information is important for us, especially if this is intrarenal, not exophytic, endophytic tumor. So it is very simple just to say that triple phase CT with angiographic phase printed. They give a lot of unnecessary cuts, here and there, hundreds of them pictures that are totally useless for us. So if they can reconstruct one panel with arteriographic phase, that is very important. So you have to ask for it.
So you can prevent the unexpected can be expected. And the other thing now, don't forget, don't limit your CT to the abdomen and pelvis. Because obviously for the staging purposes, all these patients, they need CT chest. RCS is very notorious. So make sure in one go, you get the entire spectrum done and include your CT chest also. Usually what happens is, most of the time physicians, they do the CT abdomen pelvis and we get the referral, and then again you need to ask for the CT chest. And ideally it's a contrast CT, you can cover the chest also. Imagine this patient with a marginal kidney function already had a contrast enhanced CT chest abdomen, CT abdomen and pelvis. So now you are left without a chest CT. What will you do? Will you consider giving contrast again for the chest CT or anything else?
I would consider HRCT for the chest.
Yeah, that's a good alternative if you are faced with that sort of a situation.
Won't you settle for a chest X-ray PA?
What do you think?
Small renal lesion and CT contrast enhance is already done. Marginal creatinine, chest X-ray PA reported by experienced radiologist.
Right. Doing CT, you can detect the 6 months prior to the X-ray. If there is a lesion in the chest, you can detect early with the CT.
That brings the next question. What is the chance of a small renal mass having a early metastasis in the lung?
Yes, I would like.
Yes, of course, it is a lung primary with a secondary in the kidney. So it's like an academic question. Huh?
Anything to add?
Yeah, I would like to add something to it. Nowadays, newest TAU guideline, I think 2024 one, they said like if it is T1A tumor, that means less than 4 centimeters, we can actually avoid doing a CT chest because the chances of getting a lung met of a small renal mass is very less. Yeah, so I don't think like chest X-ray will anyway add anything to that. So if you are going for a chest staging, better to go for a HRCT rather than, or otherwise just omit it.
So it's a decision of either include the chest or not.
Yeah, there is a little bit of opportunity that when you do the contrast enhanced abdomen, they get the lower part of the lung also because they go up to the upper border of the liver. So sometimes you see these little nodules, 1 or 2 there, and they comment on that, saying that the small renal mass, but there is a lung nodule as well, in which case you have to complete the series at a later date.
And in the chest, you need to look at the parenchyma as well as the hilar nodes, the mediastinum, focus both.
So what is the next step in management?
You listen to a different voice.
Since this is a small lesion, we will not go for a biopsy. It will not beneficial.
Are you sure about that? Because the size, will it stop you from doing a biopsy, or
And being a cystic lesion.
was it cystic? No, it's solid. So let's say the CT comes as it says there's a 3.5 centimeter mass in the right kidney, mainly endophytic, and it is suggestive of a renal cell cancer and contrast enhancing lesion.
Contrast enhancing solid lesion.
Solid lesion, contrast enhancing solid lesion.
Biopsy will not change in the management, anything in the management. So we better to prepare the patient for a nephron sparing effect.
Any different thoughts? Now, one opinion, basically straight away you are preparing for an nephron sparing surgery. Any different thoughts from the audience? The regional centers, please communicate.
Now she's 76 years old.
So it is a CT proven small renal mass, and it is on a 76-year-old patient. So the management options are going for an active surveillance, partial nephrectomy, or total nephrectomy, or ablation. But it depends on the patient fitness and the other details in the CT regarding the complexity of the tumor and basically the nephrometric score. So if the patient is fit and the nephrometric score is feasible, I would ideally go for a partial nephrectomy. And the renal functions also matters. And if the patient is not fit, considering the age, we can go for an active surveillance after a biopsy. And if the patient is not willing for any interventions, for a biopsy. And if the patient is stable for an ablation, still we do a biopsy and consider ablation.
Good. If the patient is very morbid and not fit for any intervention, then I'm just, it's a good answer. I'm just trying to get something more out of it.
So if the patient is not willing for any intervention and patient is comorbid, I will keep the patient on active surveillance or watchful waiting.
So what's the point of keeping a patient who's not fit for any intervention on active surveillance?
I'll keep the patient on watchful wait.
Good, very good.
So, I hope that you know the difference between active surveillance and watchful waiting. They are two different things. Have we discussed that earlier?
No.
So, what is the difference? Anybody would like to elaborate on?
In active surveillance, in timely intervals, we do investigations and see whether what's happening to the lesion that we have previously identified. And in watchful waiting, we don't do any investigations, but we see the symptomatology of the patient. And if there's anything significant only, we will investigate.
Yeah.
So it depends the goal. Your goal in active surveillance, your goal is to cure the disease. Moment it's progressive, you offer intervention to cure the disease. And the watchful waiting, basically you are managing patient as the symptomatic management, and you have no concern about the cure. Basically you keep on going them as long as they are asymptomatic.
Apart from comorbidities, what other factor will you consider to put this patient on watchful waiting or active surveillance? Apart from comorbidities.
It depends on the location of the tumor. So we have to do the nephrometric score, and we can decide what.
Suppose it is in an easy place, less low nephrometric score. You can do it. You can do it, and whether you should do it, two different things. What about the age? How long are you expected to live in this country? If you are living in bonus years, maximum 76, no? So he's at the margin. Female 76, male 73. So if you have bonus years, 79, 80, just put him on watchful waiting, because you are not going to spring into action even if it starts growing. Okay? And growth rate, you have to keep an eye on that. Less than 4 centimeters, as Roshan was saying, that very low chance that it will metastasize. Growth rate is about 0.5 millimeters per year. So those factors also into the age and the life expectancy.
And most importantly, patient's expectations.
Yeah.
When you have this discussion with the family and then always it's a very difficult task for them to decide. The family members, the patient, and we commonly encounter. Recently, I had an 83-year-old patient, the same argument. A fairly big tumor, and what to do.
Always get the patient in. Talk to the patient. Patient is more mature than their daughters and sons and daughters. They face problems better.
Yeah, it's important. You never hide the diagnosis from the patient. I never see patients without informing the diagnosis of the patient. And usually the family members, they rush in, they come, so I said, no, the patient has the right to know about the disease more than anybody else in the family. So if they like, they can see me. Otherwise, they can take the patient away. The patient has the
Another
right
thing,
to decide whatever the treatment.
Ranga,
Yeah.
Ranga, in exam point of view, whenever they encounter such case, always tell that we are going to discuss in MDT.
Exactly. That's very important point.
That is important wording that you have to all this borderline, controversial, anything you have to discuss in the MDT.
In that matter, even the malignancies, that traditionally you need to discuss in the MDT.
Yeah.
So what do you think, who are the people you want to incorporate, Dr. Manjula, for this MDT?
Yeah, the radiologist, oncologist, and pathologist, minimum. But if he has any other medical issues related to that particular field, we have to invite. Maybe if he has having cardiac issues, significant cardiac pathologist, then because we have to get about his survival and etc. So we need to incorporate.
So Nirush, your experience from the MDT from the UK?
Yes, in UK now we have incorporated a lot of cancer nurse specialists in the management and follow-up, because there are nurses who have done specializing in the cancer. So they can sometimes follow up with patients' social factors and patients' other expectations. So that is important. And when it comes to the Western countries, they are very concerned about patient psychology as well. So the fact that they are going to be diagnosed with a cancer, so it's a psychological trauma. So it's very important to have a psychological support, psychologist incorporated in this management, as well as a social worker.
I think a friendly anesthetist will be the best to replace all the physicians. Otherwise, cardiologists, endocrinologists, a lot of people have to be called. So get the anesthetist. She's the one going to go take the whole weight of anesthetizing and recovering.
Niroshan, would you take any layperson? Layperson to the MDT, patient's advocate, social worker.
Yeah, social worker definitely. And as not in this patient, but in any cancer, we have like cancer communities, groups. So we can get hold of a patient who has previously diagnosed with similar cancer, and then gone through the journey successfully. And then he or she can share the experience with this patient, and it's a very good support, especially for a cystectomy patients. In UK, they have like cystectomy clubs as such. So it's very important to give good moral support and realistic expectations to the patients.
And the next question, looking at the slide, what do you mean by a small renal mass? Definition. Dr. Manjula, Tilina, our regional centers participants, please. We would like to hear from you. What do you mean by a small renal mass?
So, I'm expecting someone to answer. If not, shall I?
It doesn't look like nobody's taking up the challenge. Yes.
So traditionally, small renal mass, everyone says the size criteria, but it's important when I put the sides also. What I wanted to highlight is it's not just the size. So it has to be a solid mass. So if it's a cystic mass, you're not going to consider it as a small renal mass, and our management will be a little bit different from solid mass. And then this is basically on imaging criteria. The other thing is it should be an enhancing mass. So enhancing solid less than 4 centimeters is what we would entail as a small renal mass, which other studies have been done, and then only we can say, okay, the risk of metastasis and then the risk of progression and all those figures are for those masses. So just the fact that it is 4 centimeters or less doesn't necessarily mean it can be classified as a small renal mass.
So three things: solid, enhancing, and size. Three things, and they
Yeah,
behave
in some
differently.
Yeah, in some studies they have also excluded if there's features of infiltrative kind of appearance. So it should be a perfectly circumferential mass rather than evidence of infiltration. So, but then that's not uniformly reported in all the other studies. So, but those other three that I mentioned before, we have to consider.
There is a question. The patient is asking if she needs a biopsy. What do you think? What are the pros and cons of a biopsy?
Pros will be we can arrive at a diagnosis. What kind of we can arrive at a histological diagnosis, and cons will be it is too invasive. Sometimes lead to tumor disseminations, and also something localized. We can it can lead to a dissemination, and also will lead to other complications like damaging to the surrounding structures. And what here that is something very not that much troublesome to the patient. So we just doing over something damage rather than a benefit.
What is your what do you think about the biopsy?
So, well, it all depends on whether to go ahead with a biopsy or not. Because if our plan, if the patient is fit and CT says it's a kidney cancer, then we can do a partial nephrectomy or radical nephrectomy. Then there's no point of biopsy.
Yes.
So the first thing come to your mind is the biopsy is indicated if there's a doubt in the diagnosis, or otherwise we are going to manage the patient non-surgically. For an example, active surveillance, yes, of course, as well as ablation therapy, yes, of course, those are the indications for biopsy. Then,
and to add to that, so basically to decide a biopsy, you need to make sure whether this biopsy is going to change your management.
Exactly.
That is the bottom line. If it is not going to change your management, no point. If it is changing, yes.
Yeah.
Another thing, Ranga, the cystic lesion, we don't generally do biopsies because it can
Yes, I'm
rupture.
about to ask about it, yeah.
Yes.
And sometimes if we are going to give upfront this immune therapies for a very advanced disease, then they might consider for biopsy for initial assessment.
Yeah, definitely. We have to consider biopsy if we are going for a systemic therapy, because otherwise we don't know whether, because I told like renal cancers are chemo-resistant. So before giving TKIs or these immune checkpoint inhibitors, we should make sure that we are dealing with the metastatized kidney cancer rather than it's not a metastatized lymphoma or any other cancer. So it's a definitive indication to go for a biopsy before giving systemic treatment.
Dr. Manjula, since you brought up this issue, the cystic ones, what do you think about the cyst? Any classifications you want to mention about the renal cyst?
Yeah, we have to because we have already mentioned the Bosniak classification. Hello?
Yeah.
Yeah, actually the Bosniak classification initially described using CT. Originally it is CT, even though now the radiologists are more confident and they report always based on the ultrasound scan. But if there's a Bosniak 2F cyst, you always need to get CT and reclassify it whether it comes under that category. So the Bosniak cyst, if it is 2F, then those cysts we need to follow up to 5 years. And if there's no interval change, no progression, then after 5 years, we can stop further follow-up. But until 5 years, we have to follow up because there's a 5% chance those cysts can develop, I mean, those cysts could be a malignant lesions.
Yes, the Bosniak, what are the categories?
Bosniak 1, 2, 2F, 3 and 4. Bosniak 1 and 2 are considered benign. 2F, the malignant risk is 5%. Bosniak 3, malignant risk is 50%. And Bosniak 4, we almost consider that chance of malignancy. We consider the thickness of the cyst wall and the septations and the heterogeneity when considering these, when categorizing into these way.
And about biopsying renal masses, these masses, sometimes the large masses, they could be necrotizing areas. So if you biopsy and if you get a negative sample, still it's not going to change your management.
Yeah.
And there's a big argument about track seeding and dissemination, sir. What do you think? Any new evidence to show that is whether it's significant?
As Niroshan said, I think there were a couple of case reports which they were not quite sure whether it was track seedling or not. But there are a couple of, so it is level 5 or low evidence. So it's a very rare. As coaxial biopsies are now done, the outer sheath will prevent the seedling altogether. Because we are doing like PCNL, you are doing the biopsy through that sheath. So very unlikely. One thing about this biopsying, if we biopsy radiologically confirmed small renal mass, if you biopsy everything, how many will be benign, how many will be malignant? What percentage will be benign?
Interesting question, yeah. Anybody, any volunteers to answer that
Radiology
question?
says it's a RCC, but you biopsy.
All the small renal masses you biopsy. What percentage that you will pick up a benign lesion as opposed to a malignant?
10%.
30%.
30, yes. Raise it. The other importance is what? Now, if we are doing a biopsy in active surveillance, and if you are doing non-surgical intervention, HIFU or cryo or something like that, why should you do a biopsy? But radiologist says that it's a cancer. So go and do a radiologist. He himself will say that I am an interventional radiologist. I will do a radio frequency ablation. But you have to still do a biopsy. Why? You know the answer. No? There are adverse histological types. When you do the biopsy, there are rare adverse histological types. Those adverse, there are 6 of them. I don't think you can remember. But those things are there. You are not going to put this into active surveillance at all.
Can you name a few?
Sarcomatous variants. Yeah.
Yes, that's a good answer, yes.
So I didn't mention because they will forget 2 minutes. But these, if you get rare opportunity of these, you take him out of active surveillance. Okay.
Rhabdoid and sarcomatid variants, the changes, they are poor prognostic ones. See.
So, medical legal issue if you give ablative therapy without histology.
Good question.
Can the patient tell that you treated a non-malignant lesion? If it's 30% benign, then the patient is having ablative therapy and maybe complicated ablative therapy. Patient party can come back and say, well, doctor, you have not confirmed whether I have a cancer or not.
What is the level of recommendation to do a biopsy before any ablation technique in guidelines?
1B. 1B. It is always recommended. No?
Yeah, it's always recommended. Manjula sir had a point. Actually, it is
a strong recommendation.
It's a strong recommendation. If we go for ablative therapy, we have to go for a biopsy. And to add to Neville sir's point, so when it comes to the chances of getting a benign result, so it all depends on the size of the tumor. So the larger the tumor, chance of being a malignancy is very high, very high. That's why we don't go for a biopsy and straight away go for operation. But when the tumor is becoming smaller and smaller, chances of getting being it a benign lesion is high. For an example, if we biopsy all the T1A tumors, there's about 20% chance that we will get the benign histology. And about the biopsy seeding, sir, and now there are they have concluded that the risk of seeding is very less. It's there was a case series. The risk of seeding was 0.05% as I can remember. So no longer it's a problem. And the other thing is the sensitivity and specificity. Because now if we go for a single biopsy, the chance of getting a representative sample is 90%. But if we go for a repeat biopsy, it can go up to 95%. So it is a very sensitive and specific as well as safe option to go ahead when we have a doubt.
And then quite correct, Nirosh, I could remember there's a review article with which they have analyzed the whole series of biopsies and they have shown there is no increased risk, significant risk of getting a tract dissemination. Particularly what they have quoted was the previous biopsy techniques and the newer techniques. So obviously the sample that you are taking, it's already contaminated in not the current practice that we are having, the biopsy techniques. So maybe with
Another
those
thing now,
techniques, yes.
newer ultrasound and etc. They do as the flow, vascular flow, and they see where the enhancing areas and etc. And they do it correctly.
Yeah.
So we'll move on to the next case. 65 years old man presents with a new onset left-sided scrotal swelling. On examination, bilateral testes were clinically normal. However, there is a grade 3 varicocele on left side. So what are the other aspects of clinical evaluation?
So this patient has come with a grade 3 varicocele on the left side, which is possible because the gonadal veins in the drains are left renal vein. But I want to do ultrasound scan of the abdomen and see whether there is obstruction at the level of the gonadal vein. There is a renal mass causing this varicocele.
So what is the additional advantage of ultrasound scan in case of suspected renal cell cancer?
Any answers, Tirina? Why do you want to put this question?
I just wanted to get everyone thinking. Sometimes we go for these investigations just by default and we just say go with the flow. But here I think why I said was depending on the ultrasound, I still believe an ultrasound number one is it will be going, we'll definitely be doing it. And the other thing is if we find if it's a large, massive tumor on the kidney, then we can plan our CT scans and further investigations, maybe include the CT chest as well. We know we have to do a staging CT. Whereas if it's a 3 centimeter tumor, well, or whatever, or then we can just do an CT of the abdomen. So see the initial ultrasound scan, we can still justify doing even if it's a, I mean, it still has a utility even if you're going for a CT.
Ranga, we need to qualify his answer that when you get a varicocele on the left side, you're thinking of a large renal tumor blocking the gonadal veins. It's not exactly that. No?
Yes.
Because that renal mass is not sitting on the gonadal vein junction.
What is the mechanism?
When it in renal when involve the left renal vein. What do you call it? Permeation.
What do you get inside the renal?
Thrombus. In that case, it can block the gonadal.
So you're worried about a thrombus there.
Tumor thrombus, yes, which is very characteristic of a specific feature of RCC to grow along the renal vein and into the IVC and go up all the way, sometimes even into the atrium. And then the question, famous question from late Dr. Gunawardhan, he always used to ask, can you get a varicocele due to right side renal tumors? I could still remember he was asking this same question from me. He had his own answer.
When this tumor thrombus extended into the IVC, there is a possibility of involving the right side.
That was his answer. So how common people having varicocele left side and to having coexisting renal mass leading to thrombus? Is it common scenario or uncommon? Now the varicocele is very common. Which side do you see varicoceles commonly? Right or left? Left side, yes. Majority of varicoceles you see in left side. So all these patients, do they have a RCC? It's not common.
It's very uncommon.
Yeah.
So what are the indications for MRI in renal mass evaluation?
So what do you think? Any additional information? Now already we have done a contrast CT and then somebody is proposing MRI. What do you think? Do you agree, disagree, or your reasons?
Ranga, can I add something? Especially when you're reporting this CT with venous involvement, sometimes with the turbulent flow, it is very difficult to identify the level. So you have to get the exact proper venous phase to identify the upper and lower limit of the thrombus. Because turbulent venous flow mimic tumor there.
If the CT suggests of intermediate lesion, so undetermined lesion, we can go for a MRI. If the patient is having impaired renal function, then we can do the MRI.
Okay, two important points we'll discuss. And any other thoughts, anything to add from this end?
In addition to that, if there's right side upper pole lesion, it is difficult to differentiate from liver masses using CT. So that case also there's an indication for MRI.
So the points highlighted, sir, one by one. What do you have to say? The first one he mentioned, what was it? Yeah, indeterminate lesions. What do you think, Nirosh? Anything to add, sir?
Uh, well, we can do MRI, but it will not significantly increase the diagnostic yield. Rather than that, if there are any contraindications to CT like pregnancy or contrast allergy, then of course MRI can be considered, and that is a valid point. We theoretically say that if we are suspecting an invasion into the liver to evaluate that, MRI can be done. I think sirs will agree with me. And I would like to add a special point because we were talking about this permeation of tumor thrombus. So MRI is very useful in identifying the exact extent of the tumor thrombus. That is in my view, I think that's the most important role of MRI in renal cell cancer.
Yeah, it is, Nirosha. In fact, the detection rates and the accuracy of MRI is much higher than the CT. The best contrast CT in terms of detecting the thrombus and the level of the thrombus in the renal vein and the IVC. The MRI is superior. And you raised a very important point. One is contrast allergy, and the third one is pregnancy. Pregnancy, you are evaluating a renal mass. Obviously, it's MRI. And contrast and MRI, the CKD and MRI, CKD and CT, anything to mention? Any difference?
The contrast we are using in the CT, it is the ipromide, and the MRI we gadolinium. So the comparing the toxicity of the gadolinium and the ipromide, and the gadolinium has less and the ipromide has high. So using even the contrast MRI won't be affecting in a patient who has been affected with the kidney disease. That's my opinion.
Anything to add, sir? Nirosh, feel free.
Ranga,
yeah.
considering MRI,
Yes.
unlike CT, because non-contrast only one phase. MRI, we can get a different T1, T2 phase, and I mean they can various modalities they can use rather than giving contrast. Giving contrast in the CKD, they can get this skin fibrosis. That's the fatal condition, but it's rare.
And the retroperitoneal.
Yeah.
What is the complication you get
Yes.
in retroperitoneal
Yes.
with the contrast MRI, CKD?
Retroperitoneal fibrosis.
So it's not completely risk-free. Remember.
Yeah, exactly. Because if the GFR is less than 60, even we rarely give gadolinium because it can lead to systemic fibrosis, retroperitoneal fibrosis, and especially the pulmonary fibrosis, and it carries about 1 to 5% chance of fatality as well. So even though we really say that MRI can be done in CKD patients, that's not the case because we are giving gadolinium. For that, I think contrast enhanced ultrasound scan carries a very good weight because it gives it uses this carbon dioxide nanobubbles for the enhancement. And if I may add, if it's a this thing Bosnia classification like for renal cyst, nowadays new studies are coming up that ultrasound contrast enhanced ultrasound scan is more sensitive than contrast enhanced CT scan, because even a slight wall enhancement can be picked up by this contrast enhanced ultrasound scan rather than CT. So it's very useful.
That is for the cystic lesions.
Yes, cystic lesions.
And the other point, now let's say you have a patient with marginal kidney function and you have decided to proceed with a contrast CT. What precautions will you take? Evidence-based answer I need.
Pre-procedure hydration. Then we have to see the serum creatinine levels. And then post-procedure, we have to hydrate as well as we have to observe the urine output. Then to evaluate, we can do a serum creatinine post-procedure as well.
Anything else?
So adding on to that, pre-procedure hydration for at least 6 to 12 hours with 1 ml per kg of normal saline, and post-procedure hydration. And during that, we can do a low dose, optimal dose of water-soluble iodinated contrast. And at the same time, we have to get a nephrology opinion. And the nephrotoxic drugs has to be omitted, like metformin and other drugs. And NAC is not considered not evidence-based at the moment.
That's what I wanted to bring out, the practice of giving N-acetylcysteine, whether there's any evidence. So actually, not evidence-based. I don't know the current practice in the UK. Do they give NAC?
They don't, but I think in Sri Lanka they still use.
But that practice slowly going away now. A lot of new nephrologists, they don't really go after this NAC.
To be honest, like in UK, in my experience, if the GFR is more than 30, without any problem, we do contrast enhanced CT scans and then hydrate the patient.
Hydrate and do it. Yeah. Now there's no real issue. A lot of nephrologists nowadays, they with all precautions, you go ahead. If it is essential, you can go ahead.
Yeah, I think just adding to that as well. So the issue sometimes is not only whether the renal functions are going to get deteriorated, it's whether the kidneys are going to get enhanced. So that's a consideration when the kidney functions are poor. Even a patient with dialysis, we can give a dialysis, but then we won't be able to get the information that we want because the kidneys are not taking up the contrast and excreting. So that's also something to be mindful of in patients with CKD, I think.
That's a very valid point, Tilina. Yeah, it's very important that we brought out that. We'll proceed.
So this is the CT scan findings. It shows a 7 centimeters left renal mass with thrombus extending to IVC with 8 millimeter pulmonary nodule. What factors would influence the management?
Anybody? Volunteers?
So the patient factors, the tube factors, and yeah, those are the most important tests. So
Yes, we'll move on and to add to that, anything else? Influence the management, the factors.
So this is technically a metastatic RCC, but it's a very tiny pulmonary nodule. My concern is it only a single pulmonary nodule? This is because if we do CT chest of all of us, couple of us will have pulmonary nodules which may be completely unrelated to it. So if we label this patient as a metastatic kidney cancer, I think it's a bit questionable. That's where the MDT comes into play. So we can have a chat with the radiologist as well as we can invite the respiratory physician and get the history from the patient and try to see whether this pulmonary nodule is actually a benign one or not. And from there onwards, in my view, if they are really concerned about it, then we can actually think about biopsying the pulmonary nodule before deciding on the management of the main renal tumor. Because in UK they use EBUS, that is endoscopic bronchial ultrasound scan guided biopsy, or if it is in the peripheral of the lung, we can do a CT guided biopsy and then rule out. But most of the time, practically speaking, 8 millimeter single pulmonary nodule, they say this is probably the benign nodule. We don't have to do anything, just focus on the management of the main renal mass and the tumor. And even though this is a small metastasis, when we do a kind of a cytoreductive nephrectomy, provided that this tumor is operable, will actually reduce the treat the tiny pulmonary metastasis as well. Sirs can correct me if I'm missing any points.
You're quite right. There's a category called oligometastatic renal cancer, where there are less than 2 nodules, where the management doesn't differ. It doesn't differ from the management of a organ confined cancer to a certain extent, because in the era of having these target therapy and checkpoint inhibitors, those things, either if the single one which starts growing later on, you can get rid of it, or if the oligometastasis disease, you can start TKIs and checkpoint inhibitors. So because of that, this nodule, I think we come across this on and off. We don't even go to the extent of biopsying it. The biopsy can sometimes lead to pneumothorax and various problems, and ultimately our surgery will get postponed. So I think the single nodule can be kept under observation, and then you can go ahead with the treatment of the primary disease.
And most of the time, these reports, they will report it's the nodule of doubtful significance or indeterminate. That's the word that they use, most of the radiologists. And the other thing, remember, the important, it's note down this nodule, because the alternative option, if you don't biopsy or anything, obviously these patients, they need follow-up CT chest, maybe 3 months down the lane or 6 months.
Exactly.
So that's very important.
Place of PET CT in this case.
Very interesting.
Well, I would disagree with that, because to my knowledge, the PET CT use this FDG, so the renal tumors uptake of FDG is very less. That's why we even don't consider PET CT during the initial staging investigations. So I think there's very limited role in FDG PET CT scan in this patient.
Yeah, I also quite agree with Niroshan.
Yes,
with this, yeah. So I 100% agree with Niroshan. So FDG PET for most other cancers, if there is this kind of a nodule, FDG PET could help. But in renal cancers, unfortunately, it doesn't. There are new studies coming up on PSMA and its role in renal cancers. But for this discussion's purpose, I think the PET scan probably is not a good idea. And again, this is a very common scenario, and I think as we mentioned almost all the time, we have to kind of ignore the pulmonary nodule and move on with the management of the RCC, because it's just a solid phase 8 millimeter, and I think less than 1 centimeter, the radiologists are very reluctant to call it anything wherever in the world, I think. So they wouldn't be confidently saying it's malignant or benign when it's sub-centimeter.
Dr. Manjula Herath, anything to add? Anything we are missing?
I mean, I don't think, diagnosing whether it's a benign or malignant, that small lesion at this stage prior to surgery has no value, because ultimate oncological management. I think best things to go away, if it's fit to go for surgery, we'll go ahead with the surgery, and subsequently with the histology and other finding, because sometimes this patient, even the tumor is in the IVC, it may be adherent to the IVC. Anyway, in that case, if the patient need adjuvant this TKI. So I don't think it has any major impact and any concern regarding subsequent management. Perhaps we can follow up during the subsequent follow-up. Anyway, this patient need very regular CTs even after surgery.
Yes, sir, that's correct.
Yeah, the PET CT, about PET CT, don't think that this is a magic bullet, Everybody thinks that this is the final thing, send him to India and get the PET CT, then everything will be hunky-dory. No, it doesn't happen that way. Unless you have like PSMA, specific molecule to which this FDG is going to get attached, where the prostate cancer is the only field you use it. The PET-CT value is just it shines up, here and there. It doesn't mean that you are diagnosing any cancer specifically. This is the thing. So until we find specific molecules to target the positron emission therapy, PET-CT is just a follow-up tool rather than diagnostic tool.
Read about PSMA PET additionally. Just go home and read.
Different
It's
story.
about prostate cancer and PSMA PET, which has an emerging role now, clearly.
I think we already discussed about this next one, no? The role of
Yeah.
cytoreductive nephrectomy in
And Kamina trial, yeah. We can skip.
Sorry, one thing that I wanted to just highlight in that about the Kamina and cytoreductive nephrectomy, it's just that people have kind of gone through the full circle, and there is evidence more for cytoreductive nephrectomy again coming up now because the TKIs are a little bit more toxic, and some people are going for active surveillance kind of thing after the cytoreductive nephrectomy, staying off the TKIs, at least in Australia. So that's what I wanted to highlight in that front.
Yeah, it's quite correct, Tilina. Now, starting TKI, when to start TKI, even for a metastatic cancer, it's a bit of a debate. Whether to start early or whether to wait until they get symptoms and start. And some of the studies show there is no much of a difference with the timing, and some say early starting it's beneficial. So a bit of an issue. I think it's mainly with the side effects.
Are we going to discuss the palliative options in IMDC poor risk disease? No, right?
Skip it. Okay. Too much.
Then we'll move on to the other case. So 58 years old male presented with macroscopic hematuria with left side hydronephrosis and flexible cystoscopy done, which is normal, and CT IVP enhancing solid lesion in the lower ureter with upstream hydronephrosis and hydroureter, and cytology was positive for high grade TCC. What is the next step of management?
So I think, Nirosh, according to our lecture, we have to rephrase the step. It is the visible hematuria with left eye.
Okay, yes, visible. Yeah. Yes.
So any thoughts about it?
Actually, this is something we didn't discuss, no, sir?
This is cytology proven, but we don't know the depth of invasion. So I would consider taking ureteroscopy and biopsy to see a depth of invasion to decide on further management.
I'm not sure whether we would really agree with the sisters ureteroscopic biopsy, whether we could evaluate the depth of invasion. Probably we'll get some chunk of malignant cells and you will say there's a malignancy. But I'm afraid you won't be able to see the depth with the help of ureteroscopy. Yeah.
The bladder.
So what is the next step? Shall we move on?
Yeah. So the next suggested next step is URS plus RGP plus or minus biopsy or washings. It has shown a papillary lesion in the lower third of the ureter, 1 centimeter in length and 3 centimeters from the VUJ. So it's in the distal ureter. Washings were positive for high grade TCC. Biopsy was indeterminate.
So now the previous CT has shown the lesion. And despite that, is it essential to do the ureteroscopy? That is the question. Enhancing lesion in the CT. So are we always doing ureteroscopy, or can we skip the ureteroscopy and proceed? What do you think, sir?
Biopsy becomes important because to get the grade. The G1 to G3 grading plays a role in whether we are conservatively managing or going to get rid of the whole system.
Dr. Manjula Herat, what is your opinion?
Yeah, whenever possible, I think we better go and take biopsy, no? If the facility is available, then we know what it is, what we are dealing.
Yeah, I would say there's a limited role. Number one, what I could think of, the more than the biopsy, the other thing, if you are thinking of rather than a nephroureterectomy, you are planning for a more limited surgery, nephron sparing, or maybe a segmental resection, yes, then you need to evaluate the entire ureter to see the spread, the extent of the lesion and the synchronous lesion and things. That's another aspect. What do you think, Nirosh? Anything else you want to add?
Well, I beg to differ. I mean, I have a couple of doubts here because it's a high-grade tumor.
Yes.
So the role of segmental ureteric resection
That's
is
exactly.
very less. So, and in my very limited experience, especially in Sri Lanka, when we do the ureteroscopy and biopsy, the diagnostic yield, sometimes I have experienced it's very less. Sometimes the pathologist will report back there's no adequate sample. That's the usual scenario. And if if it was a low grade TCC, I would definitely, I mean, I would consider, I will be more inclined to do a URS and RGP because I want to exclude any proximal lesions that I'm going to miss if I'm going for a segmental resection. But to my knowledge, I just want to ask from the expert panel that if since it's a high grade TCC already, and since we are, if I am considering a nephroureterectomy, can't I just omit the URS and RGP completely? And depending on the CT findings, as well as we have a cytological backup to tell that there's high grade TCC, and can't I just go ahead with laparoscopic nephroureterectomy?
Yes, Nirosh, I think I
Yeah,
agree.
Dr. Manjula Jayawardena, sir, what is your opinion regarding medical legal aspect of having biopsy?
There is a medical aspect. Now, if this is high grade, you're not only worried about that side pelvic health system. High grade means it could be bladder and even the other side. So limiting this URS only when it is high grade to see the proximal era won't hold because you're not putting the URS onto the other side. So now this nephron sparing in upper tract urothelial carcinoma just discussed at the Taiwan meeting. So whatever the grade, now the idea is to nephron spare because there is so many other things to manage the condition.
Okay.
So I would think disregarding the high grade, because if it is not high grade, can't even find on cytology. Only for ureteric carcinomas that are high grade, cytology is useful. And the depth cannot be also assessed. And so many now local ablative therapies are, endoluminal ablative therapies are there. And upper tract instillation chemotherapy agents are also there. Like gel mitomycin. So might as well focus more on nephron sparing now.
And the other thing, it's important to analyze the kidney function and the contralateral kidney. That's very important to decide on what to do and how to proceed.
Also, I think if somebody says indeterminate the biopsy and whether that person's cytology should be trusted is another problem. It has to be a cytologist. So this urine cytology has two sides. So be careful in taking in toto. So always a histological biopsy, to call it high grade, is better. But as now Manjula says, the grade and stage doesn't matter. They try their best to preserve the kidney if there's nothing up there. Only the pelvic, renal pelvic or calyceal advanced tumors, you consider nephroureterectomy now.
The other things are in this patient anyway, they can develop synchronous lesion even in the other kidney. So patient will be troubled, and better to save the kidney whenever possible by segmental resection.
What is the percentage incidence if you have a ureteric for the patient to develop a subsequent bladder growth or subsequent other side growth?
I think if it is upper tract tumor, the chance of having a bladder tumor is somewhere around 30%. And if it is a bladder tumor, not in the trigone, 1.8% chance of having upper tracts, but this can increase up to 8% if the bladder tumor is at the level of trigone.
So you will not compromise your segmental resection because there's a 30% chance that that bladder subsequently will develop a tumor.
Yeah.
But you're still leaving the bladder behind.
Generally, when we do the nephroureterectomy, the practice in UK is to instill the bladder with mitomycin C to reduce the recurrence. I think I can't remember the trial name, but it has shown to reduce the bladder tumor recurrence by 60% after the nephroureterectomy to instill the bladder with mitomycin C.
You mean immediately?
Yeah, immediately.
But there's a suture line in the bladder.
We do it, sir, because it doesn't matter, because we do it within 48 hours, because if we are to give mitomycin, we have to give it as soon as possible. So we give the mitomycin and leave it like that, and then remove the catheter and discharge the patient. But yeah, that's the practice.
Okay, we'll move on. So what are the management options? I think partly we have answered that. A lot of options came out. The radical surgery, the remove the entire nephrouretrectomy versus segmental resection, and then local ablative techniques. If it is a surface one, a lot of options came up in the discussion.
Just to add one thing, the ODMIT trial, actually, the mitomycin installation was at 14 days when the catheter was removed. Just, I mean, out of interest.
Yeah, ODMIT trial, no? ODMIT C, yeah.
Mitomycin was instilled not immediately, but at catheter removal, I think, if I'm not mistaken.
Okay, right.
Because Nirosha, I'm thinking since there's a suture line, you don't want to compromise the closure of the bladder, no?
Yeah, but I mean,
when they say extravasation, you don't give. Here you have deliberately cut.
yes, I mean, it's something that we practice, because maybe we not just suture it, because we stapler the line, and I think the chances of extravasation is
it's like a bubble step.
Yeah.
So at their level, we'll skip this, because otherwise they will
Yeah.
go into unnecessary.
Yeah.
Become very urological.
Yeah.
You know?
Right, we'll move on.
Oh yeah, that ends
And,
the session.
Bladder catheter.
Okay. Do we have time?
Yeah, I think we can maybe one.
So I think we can move on quickly in this question, because we have discussed most of the things. So the scenario is a 62 years old man presented with visible hematuria for 1 month's duration. How would you assess? We
can
already
check.
discussed flexible cystoscopy, and also to assess the upper tracts, either ultrasound scan or CT. We discuss how to justify the choice of upper tract imaging between the CT and ultrasound scan. I just wanted to add something. If we go for a CTI view, it will only add, I think, 10% of, I mean, if we go for ultrasound scan instead of CTI view, we will only be missing 10% of the upper tract tumors. That's one reason that in UK they have something called one-stop hematuria clinic, where the patient comes in, we do the urine cytology, urine dip, flexible cystoscopy and ultrasound scan on the same day, because we don't want to wait for the CT, because we will be only missing somewhere around less than 10% of the upper tract tumors. And this is the ultrasound scan of the 62 years old man presented with visible hematuria. Can you describe the findings and the differential diagnosis?
What do you think?
It's an ultrasound imaging showing a bladder, and there's a echogenic lesion in the base of the bladder with a posterior acoustic shadowing. It is probably due to a mass lesion in the bladder, most probably a urothelial malignancy. I'll consider in these patients.
Now there's always a worry whether this is a blood clot or a mass lesion in the bladder. So what do you think? How can we differentiate using ultrasound scan?
I think clot it can be moved with the movement of the patient. I think clot can be moved, and
That's accepted. Any other ways?
the heterogeneity probably, and attachment to the base.
Sir, would you like to add something?
Add color Doppler?
Yeah. Color Doppler.
And then you see vascularity in that.
Internal vascularity you can demonstrate with the color Doppler.
Yeah. Would you do a flexible cystoscopy at this point?
Exactly. I was about to ask the same question. Now the scan has shown the internal vascularity lesion arising from the bladder. And the question, do we really need to do the flexible cystoscopy? Can we straight away go ahead with rigid cystoscopy and TURBT?
So we can confirm with the flexible cystoscopy, we can confirm that there is a bladder growth and we can exclude the presence of hematoma. There is no additional gain with doing, and we can screen the other areas of the bladder as well.
What do you think, sir? Will you still consider doing a flexible cystoscopy?
The thing is this now, actually, this type of situation, large mass, flexible cystoscopy might not add any additional information. Better to prepare, straight away go for a CT, and then CT also confirms the thing. Plan for the TURBT. In between, doing a flexible cystoscopy might not help.
The others in the expert panel, any different opinions? Neeraj, what do you think?
Yeah, I agree with Neville, sir. I think we are not going to gain anything more by doing a flexible cystoscopy at this point because...
Yeah, me too, agreed.
Yeah.
Same opinion.
Only small thing, if you do a flexible cystoscopy, you can map out all the lesions because you are seeing the big lesion. There may be multiple lesions, depending on the location, then you can plan your thing, but it's not going to make a big difference. Anyway, when you are doing the rigid cystoscopy, you are supposed to see the entire bladder.
Is there any place to decide the mode of anesthesia, whether we are going to do by the flexible? So if we do the flexible cystoscopy based on the location of the tumor to decide the mode of anesthesia of the...
Yeah, this patient, of course, it is multifocal everywhere. So if you are dealing with a lateral wall single lesion, patient who is not very fit for general anesthesia, then those patients we can do obturator block and spinal anesthesia and deal with. But that is important if patient is not suitable for general anesthesia, then there's a place.
Yes, I think you have a valid point, not for this particular patient who has a large mass. But if it is a tiny lesion, of course, yes, then if it is a posterior wall, maybe if the rest of the bladder is normal, maybe that you can avoid a general anesthesia in an unfit patient. You are quite correct.
Yeah.
It is just a small...
Even we can do obturator block and spinal anesthesia.
So
Lateral wall one.
Considering the size of the lesion, what's the place for MRI? We can go for a straight MRI and decide the management. Pre-biopsy MRI.
MRI.
Yes. The CT. So you are doing the contrast enhanced CT IVU prior to the TURB anyway. So you're thinking that MRI scan to assess the bladder lesion. That's what your question.
Yes.
The only argument was that the MRI will give the depth of invasion better than CT, but that's not going to be useful for us because we are going to do a TURBT and invasion of muscle is decided only on that. Whether MRI say it goes through it or not, it's our TURBT and the biopsy. So
to add to that now, there's a slight difference between the world practice and the Sri Lankan practice. Now, if you are in the best centers where you have easy access to MRI, perhaps now the emerging trend that the people would go ahead with MRI provided it's confined to the bladder because they would like to assess the depth and all these other the facts based on the VRAD score now. But in the local setup, definitely getting an MRI is a nightmare in most of the centers, and I don't think any of us would waste time on MRI for a bladder cancer. Once it's clear, we all go ahead with the TURB. And as Sir said, whatever the final decision, whether it's a muscle invasive or not, that is not based on your imaging. That the final confirmation basically based on your histology. Therefore, that will not change your management at this point.
Never do the CT, IVU or the MRI just after the TURBT. There's a thing called TURBT effect. It's always been reported as muscle invasive and T3. So it takes little time for that to settle. So always do the contrast study before the resection.
Ideally before the resection, because after that all the post-surgical artifacts will appear and it will be staged in the imaging.
Would you do any other investigation in this 3 centimeter bladder mass? As for the staging investigation, so we have already discussed CT chest can be done, yeah. And then the CT shows unifocal 3 centimeter bladder tumor over the right lateral wall. And this is the cystoscopy findings. And I mean, during the cystoscopy for TURBT, what are the important points during TURBT in tumor in a lateral wall? We already discussed, I think, about the obturator jerk. That's the main concern. So either you have to do the surgery under general anesthesia with muscle relaxants, or otherwise, as Manjul Heratz correctly suggested, if the patient is not fit for GA, spinal anesthesia with obturator nerve block. And I want to highlight one point. It is very close to the ureteric orifice here, right side ureteric orifice. So this is another definitive indication to go for a upper tract imaging in this kind of patient because of the higher chance of getting upper tract lesions. And what do you do at the end of the TURBT? So since the time I'll tell, so you have to put a catheter and instill mitomycin C because it has shown it reduces the recurrence by 39%. And mitomycin C actually indicated in intermediate risk cancers, not in high risk or not even in low risk. But the problem is by the time of TURBT, we don't know whether we are dealing with the intermediate risk category or not. So because of that, the practice is to give mitomycin C for every patient, and it has to be given as soon as possible to increase the effectiveness. But I think in Sri Lanka, we don't have the facilities to give mitomycin C.
We do have.
We have.
We do practice. I practice in both the government sector and the private sector. All the patients who undergo TURBT, and I'm sure a lot of other centers they practice now.
Right. Okay.
The thing that if it is clinically muscle invasive, where we are living with a lot of residual disease, and is a bulk of tumor is still left, mitomycin plays, I don't think.
Yeah.
If it is clinically muscle invasive, you can see the residual disease at the base.
Exactly. Yeah.
This is for the non-muscle invasive. If you think that, if you are dealing with, if you clinically dealing with non-muscle invasive disease.
While resecting, it's very difficult to say it's muscle invasive or not, number one. But if you see a sessile nodular lesion, then of course you are pretty sure that it's a muscle invasive tumor. And then of course it's doubtful whether the intravesical BCG is going to help, except that if there are any CISs. Now, if you are clinically, now you feel that, the CT reports is a muscle invasive, MRI reports muscle invasive, macroscopically is muscle invasive. After cutting, putting the BCG doesn't give any...
the BCG, or you are referring to?
Sorry, MMC doesn't give any other advantage. So that is the only time I will just reconsider putting it immediately there.
Niroshan, according to the practice, you said everybody gets it, no?
Yes, after the TURBT, because by the time of TURBT, we are not very sure whether it is muscle invasive or not.
So he's asking from the audience the same question coming up. Pre-operatively, if you are quite sure you are dealing with a muscle invasive disease, or maybe perhaps the disease going through and through to the exterior of the bladder wall, still whether do we need to give mitomycin C?
No.
Then in that case, no. If you have enough evidence, then no.
And since we are very interested in pre-operatively deciding whether this is muscle invasive or not, Ranga sir discussed about VIRATS classification. Now there's a trial going on. The idea is to omit this diagnostic TURBT completely and to see whether this MRI and VIRATS classification can actually replace and predict the muscle invasiveness. So straight away we can go for cystectomy depending on the MRI findings rather than wasting time on wasting time on the TURBT and the second TURBT, but still it's going on.
So it's still at your level, it's only research. So you stick to TURB is the must, and then we proceed.
Yeah, I think that.
In time to come, things may change.
Yeah. Then when the patient comes to your clinic with the histology report, what are the important points to be checked on a histology after TURBT, first TURBT?
Whether there is muscle invasion, or if not, whether the muscularis propria is included in the specimen. If not, we need a re-resection and the presence of the grade of the tumor.
And I think
as you mentioned, like grade, T stage, muscle present or not, and if it is present, whether it is involved or not, presence of carcinoma in situ, as well as type of histology. Neville sir discussed about the variant histology importance in renal cell cancer, but here also it is very important. If there's like sarcomatoid variant or any other variant, one thing is prognosis is very poor. It automatically becomes a high risk bladder cancer, as well as if we go for a second TURBT, the chance of advancing it to a muscle invasive disease is more than 50%. So always if there's a variant histology, that's a bad sign. Yeah.
And one more thing, grade stage. And the other important thing is lymphovascular invasion. That is also important. That has a clear relationship with the prognosis.
Yeah. Sorry, continue.
No, sir. The lymphovascular invasion in the histology sample, the bladder tumor, that has a clear prognostic feature.
Then this is the histology report. It's a grade 2 low grade TA TCC. Muscle is present, but it's clear. It was a solitary tumor, though it says 3.5, the sample says 2.5 centimeters. And how do you classify the bladder
Before
cancer?
that, can I ask a question, Niroshan? How do you assess the size of the bladder tumor?
Ask it every year, no?
Anybody?
All under magnification. Tumor looks like this.
Yeah, you are resecting with the magnification. You have the large view, so how do you get the size?
So this is a fun common sense question.
Yes. Huh? Size of the loop. So you can explain, sir.
Yeah, yes. You know, the loop, it's about say 1 centimeter, the large 24 one. So you compare it with the loop length. Same thing we do when you crush stones. You compare it with the laser fiber. Laser fiber is 0.5 millimeter, then 4 millimeter stones will come out.
Depending on the fiber size.
So whether you have crushed it into small pieces, that's how we find. Compare it with the instrument.
And what is the risk group? I have mentioned like nice risk group because nice divided into low, intermediate, and high risk.
So, but I think that
they don't
their
need to-
level, you don't have to
yeah,
know the
okay.
risk categorization.
Okay.
I think how to classify, you don't have to know. That's beyond your level.
So how are you going to follow up a patient with these histological findings? So I think we already discussed it is by doing routine cystoscopy, flexible cystoscopy, because bladder cancers can recur notoriously. But since actually this is a low risk bladder cancer, so the risk of recurrence is less. So because of that, we have to do a cystoscopy in 3 months' time, and then again 6 months' time, again at 1 year's time. And UK practice is to discharge if there are no recurrence, but EAU, the European countries, they keep on following up them till 5 years. But I think considering our setup, like we have a lot of volume of patients to be followed up. So that's what one reason I put this question. So would you agree that we can also adapt to this, and for a low risk bladder cancer, if we can discharge them in 1 year, is it good idea or not?
Yeah, papilloma, pun lump. Pun lump is a low-grade malignancy, and TA. They are tiny little prawns with a tiny little stem. Once you get rid of that, if the biopsies show there is no CIS, you have to take some biopsies because you don't know whether there is CIS. Then, of course, 9 months after 3 months, 9 months, and then of course it's negative, we can discharge them, but I won't do it personally. At least I'll do another one in 1 year's time at least. And then if there are no signs of it, we probably will ask them not to come. But I think the guidelines are and practice
It's
here.
changing
Because
depending
people
on the
disappear.
cost,
That's the
cost
problem.
effect and all these things. And then the UK and the rest of the Europe, the guidelines are slightly different.
Yeah.
All right.
I know UK, it's just 1 year.
1 year, yeah.
1 year. But some of the European guidelines, I think they go up to 5 years.
5 years.
5 years.
Even the lorries,
Even
they
lorries,
go
they
up
continue.
to
EAU
5 years.
guidelines 5 years.
And if it is high risk,
Nice.
lifelong.
One. Yeah.
Nice, nice.
After 1 year, they discharge.
Nice 1 year. So I'll give a different perspective for this. My question is, would you have done anything else if the histology shows T1 G3 tumor that actually I just wanted to show that it's a high risk one, and also the fact that you need to go for a secondary section or second TURBT. Sir, what is your opinion on doing a second TURBT in patients?
All T1 G3 T1 G3 tumors definitely need a second look after 2 to 6 weeks, between 2 and 6 weeks, with deep cuts, because sometimes it gets upgraded by 20 to 30%, saying that muscle invasive cancer is there. So T1 G3 is a separate kettle of fish. So that is a high risk one. And then always when you find that, get biopsies all over the random biopsies from the bladder, because there can be associated high grade PIN. CIS. So I think I would go for a second TURBT in this case, and in that case T1 tumors also. All we will go for T1 means superficial, they're non-muscle invasive, but again that will get upgraded to muscle invasive if you go for the second biopsy.
So these are the indications for second TURBT. If it's a T1 tumor and the muscle is absent on the sample, histology sample, and of course, if you know that you have done an incomplete resection, then of course you have to go, and as Neville sir said, I think we can add, if it is a high grade or G3 tumor, that's also an indication to go for a second TURBT, and it is done between 2 to 6 weeks time. So this is about high risk non-muscle invasive disease. High risk means there's a higher risk of recurrence, and most importantly, high risk bladder cancers can progress into muscle invasive disease. So what?
Two things: recurrence and the disease progression.
And what are the options available if your bladder cancer is a high risk bladder cancer? So I have already given the answer.
We'll go fast because it's not relevant, no? So it's
Yeah.
training.
Yes.
Not that just to let you all know that there is some options.
So we can give intracycle BCG or go for upfront cystectomy. What is BCG and how it works? So it is actually the same BCG we give for immunity. It is a live attenuated Mycobacterium bovis vaccine variant, and it creates a cell-mediate immunity and prevent or attack the future bladder cancer cells and prevent the recurrence and progression. And when you should defer or not give a dose of BCG, as Manjula sir correctly mentioned, if there's a ongoing hematuria, we can't give. If there's a symptomatic UTI, we can't give. And we generally wait for 2 weeks to give BCG after TURBT, unlike the mitomycin C, which we give immediately.
The bottom line is basically there should not be any row surface over the bladder at the time you are giving the BCG. Because if there's a row surface, the absorption, systemic absorption is very high, and which could lead to a lot of side effects, especially hepatotoxicity.
Always avoid quinolones when you are giving BCG.
Yes.
Because it's anti-tuberculous drug. So like ciprofloxacin, levos, should avoid.
Avoid them.
What are the potential side effects? The BCG is a very toxic drug. So these are the side effects. As you can see, the dysuria and frequency, almost half of the patients will develop this, and low-grade fever, myalgia, and also systemic BCG infection, though rare, can cause fatality, and granulomatous prostatitis and bladder contracture, ureteric obstruction. All these are the side effects of giving BCG.
Immunocompromised people can get full-blown miliary TB.
Yes.
As well.
And some joint involvement also, sir.
Sorry?
Joint
Oh,
pain
yeah.
and joint involvement with BCG.
So we'll quickly move on to the second case. 74 years old man coming with 4 weeks history of painless visible hematuria. He's having hypertension and diabetes mellitus. Ultrasound scan done and also flexible cystoscopy done, which showed 8 centimeter solid tumor in left lateral wall. How would you proceed? So we have to go for a staging CT and TURBT under GA if possible with muscle relaxation. And when the patient came to clinic, it comes as G3 T2. And staging investigation didn't show any lymph nodes or distant metastasis. So basically, this is a localized muscle invasive bladder cancer. So this is a MRI pelvis, not the CT, and it clearly shows it is going beyond the bladder wall. So I would say it's somewhere around T3B.
And it's a large volume disease, filling
Large
almost
volume
half of
disease.
the bladder.
Yeah. What would you do next? So in these kind of patients, we have to always go for MDT discussion because it's going to be a challenging management, and you have to assess the renal functions of the patient and also the performance status. That means the fitness of the patient to decide on further management. And MDT confirmed it's a T3B TCC, no lymph node metastasis, and renal functions are good. Performance status is good. So what are the treatment options? Of a muscle invasive bladder cancer in a fit patient?
The treatment option is the radical radiotherapy or radical cystectomy.
Good. Yeah, those are the two options, either radical cystectomy or radical radiotherapy. And one important point. So if we have to consider neoadjuvant chemotherapy prior to either options. Not only the cystectomy, but also the radical radiotherapy.
That has a survival advantage.
Yes, it has a survival advantage. But that is about 5%, but still they consider it as
some of the
significant.
centers.
Yeah. After cystectomy, this is the other question they can commonly ask at the exam. What are the types of urinary diversions you know? How do you classify the types of urinary diversion?
We can classify the incontinent and continent urinary diversion.
Good. Yeah. So examples, yeah.
Yeah, incontinent ileal conduit, and then continent we can do a orthotropic neobladder and.
Yeah, I have shown photos. So ileal conduit on the left upper photo, and the neobladder on right upper photo, and the bottom one is the ureterosigmoidostomy, which we no longer do.
Yeah, exactly. We don't do ureterosigmoidostomy any longer. Any particular reason? Now, good olden days, they used to divert the ureters into the colon, sigmoid colon. But in modern practice, we don't do that now.
So, sir, metabolic consequences of high risk of incontinent fecal acidic.
Yeah, a lot of reasons. One is the metabolic reasons, ascending infection, pyelonephritis, because you are directly opening into the sigmoid colon, and long-standing patients who are on diversion beyond 10 years or more. What will happen when the gut wall, the sigmoid colon, and the rectum get exposed to urine long term? Yeah, risk of malignancy is high. So they all need screening beyond 10 years. For those reasons, now we don't perform that. So it's old practice now.
Hypochloremic acidosis, the main thing, they come and die of come panting, and then after 3 months they die. So if you are doing that for any reason, put them even ileal conduits, long ileal conduits, they can absorb urine. And hyperchloremic acidosis, you have to put them on potassium citrate or bicarbonate, 1 gram per day for rest of their lives. It's a lifelong treatment. Otherwise, they'll end up in, and keep an eye on the electrolytes.
Yes.
You're doing it.
Yeah.
All bowel segments, when they are used, keep an eye on this hypochloremic acidosis.
Yes, that's what sir was talking about. So these complications can happen when the bowel segments are incorporated into the urinary system. This is the other question that they can commonly ask from you all. So yeah, that concludes the session.
So any questions? Unfortunately, we never had any questions from regional centers, probably crystal clear, or everybody's sleeping and nobody's joining. Any questions from the audience? Please clear all doubts before the exam. You don't have a better panel like this to ask all these things. It could be a stupid one, but it's important for everyone. You may think it's stupid, but everybody else will be hiding the same question and you will be benefiting the others.
Sir, what are the options if the bladder is perforated while we are doing the TURBT?
So first thing is not to panic. Then you have to decide whether you have completed the TURBT or still more resections are there. Because although you see a huge rent, that is because of its 10 times enlargement. So suppose, let's say the worst case scenario is you have perforated the dome of the bladder and you can see the appendices epiploicae floating on the other side. Or the anesthetist is saying patient is going into hypercapnia. No?
Airway pressures will go up.
Hypercapnia and airway pressures going up. So that is, of course, will signal that you have to open from the top and close the lesion. But suppose you have a bladder injury on the sides, peritoneal cavity is not open, then of course you can decide. Now the problem is whether you are completing your TURBT or abandoning. That is also depending on your experience, you can decide. And remove whatever the material that you have, detached and floating in the particles, and put your three-way catheter, but try not to irrigate. So you put the three-way catheter and stay without irrigation or run a small irrigation. But when there is interventional radiology is available, you might decide rather than to explore, drain the peritoneal cavity percutaneous while draining the bladder.
Usually the bottom line is if it is intravesical or extravesical perforation, the management is different. Intraperitoneal. So if it is intraperitoneal, you need to close and they are going to leak and the urine going to get collected within the peritoneum. Extraperitoneal, you can manage conservatively. But if it is a large one, significant one, there is still a chance you get urinoma and urine get collected outside the bladder, even extraperitoneal. And those cases, sometimes you may have to place as I mentioned, a drain, extravesical drain to get the urine out. Usually it settles
Other
on
thing,
its own.
other thing, Ranka, whether we use water or saline.
Yes, that's also important.
Yeah, that is a matter.
And the antibiotics, no, sir?
And the antibiotics and continuous bladder drainage with the catheter. How long? 10 to 14 days, textbooks, 10 days. Maybe the elderly people, poor healing, probably even up to 14 days. There's no hard and fast rule. And other countries, I'm sure, they before they remove the catheter, they will make sure they do a contrast cystogram. Demonstrate it's all closed, and then only they will take out the catheter. But in our practice, we don't do that. But ideal management, yes, that is a practice. Those days, I don't know now.
Now also 10 days cystogram and then remove the catheter after that.
Any other questions?
There's a question.
Considering the muscle invasive cancer, the treatment option are the radical radiotherapy or the radical cystectomy. But is it same like the radical radiotherapy of the prostate, or is it in the prostate it is curative? But when it's come to
You're asking about the dose or the?
considering the bladder, is it curative?
Yes, it's curative. It's curative.
When you say radical, it's
Radical word you use when you cure something.
cure. Otherwise, there is palliative radiotherapy, but that is to for bone mets. No?
And so palliative radiotherapy, there's an option if they start coming with repeated bleeding, advanced cancers, repeated hematuria, there is a place for palliative radiotherapy.
What about the trimodal?
Asking about the trimodal treatment and the bladder preservation.
It is the newest, I mean, it's not newest. It is something coming popular from the uro-oncologist side because nowadays people are more concerned about being less radical and going ahead with bladder preservation therapy. So radical trimodal therapy, it has proven to show very good effectiveness. Actually, I would say equal effectiveness for radical cystectomy. There we do a maximum TURBT and combine it with radiotherapy and chemotherapy. I think the trial, I can remember, Tilina can correct me, I think it's checkmate trial, as I can remember, Tilina. Yeah, but it is becoming more and more popular, and there are reports to show that it is equally effective to radical surgery, and the patient gets to keep their bladders.
Yeah, I think now we are picking up small muscle invasive tumors. The size, exact size to decide on trimodal or cystectomy has not been defined yet. So like small renal mass, the same concept is being transferred to bladder. So tiny muscle invasive but small. So those things, selective group, trimodal therapy and radical cystectomy, they give the same outcome. So you can do that.
And I think the one area which we didn't discuss, touch upon is BCG failure.
Yeah, that is a cystectomy.
Yeah. BCG failure, if you are treating high risk bladder cancer, BCG failure, then you are left with cystectomy, the next step. And radiotherapy, if they come with recurrence, then again there's a place for salvage cystectomy. Following radiotherapy, still they are coming with either residual or the recurrent tumors. That's another option available.
The therapy you have to now take it with a pinch of salt also, because a lot of industry driven, because those chemotherapy regimes are so costly, and since it is so costly, industries would love for you to keep the patient's bladder and keep on treating with their products. So until some good results come, we have to consider the radical cystectomy or radical radiotherapy is more reliable. Because you won't know why there's so much of articles coming in support of it. No, they are not all bona fide.
Yes,
that's also better to remember in the practical world.
Yes.
And when you decide between radiotherapy and surgery, always consider patient factors, performance status, their fitness, and that's one of the main factors, age and the patient fitness.
Yeah.
Whether they would tolerate a long surgery like radical cystectomy, or whether they will be better off with radiotherapy.
Radiotherapy is also not devoid of complications.
Complications.
There are so many. So especially the hemorrhagic cystitis is something which was really bothering us. They start bleeding like hell and then you can't stop. So you put alum and various blood installations, formalin, and then thereafter ultimately you end up in doing bilateral embolization. That also doesn't work.
Then the diversion.
Still vegan, you just divert. You don't do a cystectomy, just divert. When urine is not touching the bladder, it stops bleeding. Because urine has urokinases, which dissolves the clots.
Yeah.
So you have to go to that extent. And also radiation around the place.
And remember this radiation cystitis, it's not immediately. Even after 10 years of the radiation, they can come.
Yeah.
So it's not, there's no time limit.
And there are patients who can't have radical radiotherapy, like patients with inflammatory bowel disease, if they had any pelvic radiotherapy for a previous pelvic cancer. So that's why radiotherapy is not a universal option for any patient. In that case, still good and old radical cystectomy and ileal conduit has a better place.
So if you meet a urologist versus oncologist, always the debate will come up, which is better. Oncologist will favor radiotherapy, whereas the surgeons would say surgery. I hope it's a surgical audience, so no conflicts.
Fortunately, for the oncologists, the prostate arena, they are winning slowly, but not in the bladder. Still, there is no evidence to show that radiotherapy is better when it comes to muscle invasive cancer, when the indications are there. So that's why all guidelines says that trimodal therapy for a selected small group of patients.
Any questions before we wind up? So let me thank all the resource persons, starting from Professor Neville Pereira, Dr. Manjula Vijayavardhana, Dr. Manjula Herath. And then I should mention Dr. Balagobi from Jaffna. He was really behind this, but unfortunately, because of the funeral, he said he need to withdraw. And then Dr. Niroshan Kodikara and Dr. Thilina Samarasinghe. All the cases, thanks to Niroshan and Thilina. They did all the cases and then the presentations by Niroshan. So it's a team effort. Thank you so much. All of you on behalf of the College of Surgeons, I would like to thank all the resource persons and all the regional centers who have facilitated and joined with us. Thank you for joining and hope you got some benefit from this session over last 4 hours. So hopefully now next month, it's September. So it's a college sessions, a lot of pre-congress, post-congress workshops are going on. So traditionally, we are not conducting any sets during September, but hopefully we will meet you in October, November, December. So September, there will not be any sets program lined up. Okay, thank you for your participation and attendance. Thank you. And one more thing, our sponsors. The general sponsors today, it's Sun Pharma. So the gratitude to all the sponsors who have been sponsoring throughout different companies. They are really helping to maintain and fulfill the logistics. Thank you.
Shall I stop share?